I'll just do that.
कांटा नहीं है कोई इधर कांटा रख दो
Dr. Vandana Dayal.
Is the first candidate there? Has she logged in? No.
No, not yet.
Okay. So we start at 9, no?
Yeah, we'll start at 9.
Sristi, we are live and you are the host now, no?
Yeah, okay.
I'm leaving my.
Huh? बड़ा बेकार अमरूद है
सॉफ्ट हो गया
ज़्यादा ही सॉफ्ट हो गया I don't like such अमरूद
न्यूट्रिशन तो है ही
Dr. Vandana, are you there? Dr. Vandana Dayal?
Has Nilima joined? No.
Sorry?
Nilima is joined, na? Haan. Neha, Sonakshi, Srishti. Nilima, are you there? Hello?
No, she's not there yet. She's not there
Not
yet.
there.
Yeah.
Who are the judges for the first lot? Dr. Vani and Dr. Babita, they are for the first lot.
Yeah, I have not
four
given
names.
that name. I've just given the names of the coordinators right now.
I have got 4 names, Dr. Vani, Dr. Babita, Dr. Poonam and Dr. Rehana.
Okay, okay.
Me, myself, Dr. Vani, I have joined in, madam. Good
Hello,
morning.
Dr. Vani, how are you?
Good morning, ma'am.
You're for the 9 o'clock session?
Yes, ma'am. And
Okay.
I'm just right now logged with my mobile. I'm going to log in with my laptop now.
Okay, okay. राम जी मेरा अंडा कहाँ है? अच्छा तो अगर इसमें साउंड नहीं आएगा तो वो तुम अब 10 बजे क्लास खत्म होगी ना तुम्हारी, उसके बाद फिर इवनिंग वाला सेशन देखते हैं। कोई प्रॉब्लम होगी तो तेरे को फोन कर दूंगी।
हाँ, लैंड फोन पे कॉल कर लीजिएगा।
ओके, अच्छा।
ठीक है, मम्मी उठा के फिर मुझे बोल देंगे 10 बजे तक मैं क्लास में।
ये वैसे सही है ना?
हाँ सही है।
मैं तो गई व्हाट्सएप वेब से गई हूँ उसमें।
हाँ हाँ,
ईमेल से तो वो एरर ही नहीं आ रही है।
आप म्यूट पे रखिए।
अच्छा ठीक है, चलो ओके।
डॉक्टर नीलू, गुड मॉर्निंग। तुम अपना म्यूट करो। हेलो, हाँ मैम,
गुड मॉर्निंग।
गुड मॉर्निंग मैम। स्लाइड शेयर आप करने वाले हैं?
जैसे
जो
आप बोलो,
हमारे
आपको करना है आप कर दो।
हाँ जी,
आपको करना है आप कर दो।
वॉट एवर यू से। तो मैं 1 मिनट इसको फिर वो कर रेडी कर लेती हूँ, ठीक है? मैं फिर आप उस यू विल स्पीक आउट विद द स्पीकर्स, ठीक है ना? मतलब आपको उनको।
अच्छा, फर्स्ट सेशन के अंदर तो डॉक्टर वानी एंड डॉक्टर बबीता।
जी जी जी, सिर्फ वही दोनों स्लाइड्स मैम आपको करनी है।
हाँ, और डॉक्टर पूनम और डॉक्टर रिहाना नेक्स्ट सेशन में।
वो नेक्स्ट सेशन में तो उन्हें 11 o'clock पे इंट्रोड्यूस करना
हाँ हाँ, ठीक है ठीक है।
है ना? तो मैं करूँ फिर स्लाइड शेयर?
हाँ हाँ करो।
ठीक है मैम, 1 मिनट। अच्छा ठीक है, बहुत बढ़िया।
तुम्हें फाइनली वाईफाई मिल गया हॉस्पिटल से?
हाँ जी मिल गया।
गुड गुड।
हाँ, बढ़ेगा जरा सीमा प्लीज, थैंक यू।
ये सारे टाइम बैटरी खत्म है क्या?
अरे आपकी वॉच में सेकंड्स है? वॉच में सेकंड्स है?
मेरी वॉच में
ठीक है होगा।
ये आपको
हाँ हाँ, आपको यहाँ पे टाइम देना है। 6 मिनट्स का एक स्पीकर है।
Mr. Somebody from IT is there?
Yes, ma'am.
Ritu?
Ma'am, my name is Srishti.
Okay. See, when I'm sharing the slide, they are showing that this will stop
One
sharing
second.
other screens,
Yes, my
screen
is just
sharing.
dead, no? Yeah.
So do you want to continue? So what do I
I
do?
am just stopping my screen share. Yeah, your screen is there now. Anita Gond, Anita Gond is sharing the screen. May I request Ms. Anita Gond to stop sharing the screen so that Dr. Nilima Agarwal can share her screen?
Thank you. हाँ, इसमें है। आपको ये घड़ी अच्छी है, ये भी वहीं रख दीजिए।
Ms. Anita Gond.
Anita, huh? She has shared the screen.
Dr. Nilima, you can share your screen now.
Okay. Yeah, my screen is, I think, visible to all.
Yeah, ma'am, just make it in a slide mode.
Achha, Dr. Vani is here with us. Hello, Dr.
Yes,
Vani. Good morning.
Good morning, Dr. Nilima.
Nice seeing you.
Thank you so much. Thank you.
Dr. Babita. Has Dr. Babita also joined?
It was she only who told me that we'll all be there by 8:15. I said it's too early. She
Huh.
said, even I thought, because of that all digital check and all,
I
so it's
swear.
better to join in time. So I think she was reminded and I think hasn't joined as yet.
Okay, Vani is very punctual and looking very fresh and nice.
Thank you so much, madam. Thank you.
That's really nice. Do we have our participants with us? The first 5 participants: Sudhakshi, Yapi, Fatima, Asha, Mrinalini. Do we have them all?
I don't think anybody has joined so far.
We have many participants.
Mrinalini is there.
Just see, Yapi.
Yapi is there.
Yapi is there. Fatima is there.
Yeah, Fatima was there.
Mrinalini is there.
Mrinalini is there. Asha Saxena and Anita Gond. Anita was there just now.
Yeah, Anita was there, but I can't see Anita right now. Yeah, Anita is also there.
Anita is there.
Yeah, Anita is there.
Yapi is there. No? Yapi. Her name is what?
Yapi, Margin.
Margin. What's the time? I see that.
Sudhakshi is not here. Yapi is present. Fatima is also not here.
Dr. Vani, you are in the hospital right now, or you've logged in from?
Yeah, this is, my skill lab.
Okay, right.
I'm sitting in my skill lab.
Okay, that's really nice.
Actually, we have, this person facilitates the laptop and everything Zoom. So if there is any technicality, then he is always there. So I called him here.
That is really important, actually. I'll take off my. At least the first speaker is there with us, no? Yeah. Yapi is the first speaker. No?
First one is Sudhakshi Kinga, no?
Dr. Nirma, may I request you to share your screen in slideshow mode?
Sure. Just a moment. Is that okay?
Yeah.
Hi, Poonam. Good morning.
Hello. Good morning, ma'am.
Good morning. Nice seeing you.
Hello, Poonam. How are you?
And I'll introduce you.
I was taking lecture at that time.
Dr. Vani, she's our guest for the first session. She's HOD from Gorakhpur, Poonam, and Dr. Poonam is HOD from Bareilly. She will be in the second session, but she's very sweet to join right now, and we'll be there with you. Has Dr. Babita joined till now?
No, Dr. Babita not yet. I can't even see the first participant yet.
What's the first? Sudhakshi? I think Sudhakshi was there right now.
No, not yet. I can't see her.
Her name is not there.
Sudhakshi is not there.
No.
Who's the next? What's the time?
It's 8:56. We have 4 minutes now.
I think we okay. Shall I call Dr. Babita to find out if she has any technical problems? I'll just I'll find out. Then we will.
I'll just put you on mute.
I'll put myself on mute.
ये ठीक है सर रहने दो
अमृत खाली सब तो क्या
We can take the second candidate if the first one hasn't joined.
We can wait for 2 minutes. Next 2
We
minutes.
start at 9. Yeah.
Yeah, Dr. Babita is just joining in another 1 or 2 minutes, and we'll start the session. If the first one is not there, we'll start with the second one. But just let Dr. Babita join. और पूनम तुम्हारा इस टाइम पे क्या चल रहा है पूनम? You are in the hospital?
Actually, you know, everywhere there is so much noise and intruders into your room. Yesterday also I had some Zoom meeting, and then everybody being HOD, everybody peeps in and you can't say no sometimes, and then the session gets late.
I swear.
So I thought, let me sneak into a place where nobody knows that I'm here.
That's really
and let
true.
them think whether I'm there or not. Till 11 I'm here, then I'll go and take a round, and then again we have at 12 o'clock some meeting. And Dr. Reena had invited me yesterday, so I said, sure ma'am, thank you. So 12 o'clock, then I will join back after the rounds.
Yeah, actually this is it. The liabilities as HOD are so many, no, you can't say no. Just let me know once Dr. Babita joins and we'll start the session. You can see my slide, no, Dr. Neelu ma'am?
Yeah, I can.
Yeah. So how
we have 1 minute to go.
Can we shift it?
Just move to the next slide. See if it is moving properly.
Yeah, it's moving. Once Dr. Babita joins, then we can, because we have only 2 speakers or these judges, no? Yeah, it's moving properly. बता देना डॉक्टर बबीता ज्वाइन कर ले.
It's exactly 9 o'clock.
Okay.
Yes, I think one minute.
Yeah, I think we can start. Dr. Babita will join. She's just in the process of joining. So I think I'll start with the session.
Sure.
Ma'am, Dr. Neelu ma'am, I'll just introduce this thing, then you can introduce the judges. Good morning, dear judges and students. I'm Dr. Neelima Agarwal, Professor and Head at Santosh Medical College, Ghaziabad. And I welcome you all on behalf of UPCOG 2020. This is Hall Yamuna, and we are going to start with the free paper presentation in this for the postgraduate students. My co-coordinator is Dr. Neelu Khanija ma'am. She is the senior consultant gynecologist at Ghaziabad. And now I hand over the mic to Dr. Neelu. She will be introducing our judges. Yeah, Dr. Neelu ma'am.
Welcome, Dr. Vani. Good morning. So she's our first judge. So she's a professor and head of BRD Medical College, Gorakhpur. And now I think we can go ahead with the meeting. The first candidate, if she's there, Sudakshi Skinger, are you there?
No, she's not there yet.
We'll call the second one, ma'am.
So Dr. Babita is the second. She's the consultant in charge of gynae department, endoscopy surgery, Pushpanjali Hospital, Agra.
Has Dr.
Babita joining us yet?
Has Dr. Babita joined?
No.
Okay. Once she joins, she'll continue.
We will introduce her again.
Sure. So we have our first speaker with us. Yapi.
Yapi was there.
I request please the speakers to be ready with their slides one after the other. You have the chronology with you. So if Yapi is also not there, we'll go with the Fatima or Asha Singh. Whosoever is ready, please let me know. Unmute yourself and we'll start the session. Yapi is there.
I can see Yapi.
Yeah. Yapi, are you ready?
Yes, ma'am. Good morning, ma'am.
Good morning. So you can share your slides and start your study.
Actually, I'm not getting the options for sharing. Okay.
Please.
Below the screen, you will see the share screen option in green color.
Yeah.
Miss Yapi, there's this screen share option.
Yes, ma'am.
Have you logged in through your phone?
The coming, the unsupported documents.
You have logged in through your phone?
Hello?
Yeah, ma'am.
Yes, ma'am.
So in the phone, you can't play the presentations. You will have to use a desktop or a
Ma'am, I
laptop.
have sent my PDF in.
You've sent your PPT to whom?
Email. I have emailed it in UPCOG, ma'am.
See, I'll tell you one thing. You'll have to send it again to either me so that we can slide share.
Tell her to mail it right now. Then we can go to the next one.
Yeah, sure. We'll have to go with the next candidate, ma'am. Till then.
Yapi, you mail it right now.
Yes, ma'am.
Who's the next candidate? Is Fatima there? Asha Saxena is there?
Anita. Anita God was there. Asha Saxena, I can see.
We can ask Asha Saxena, ma'am, to let her start with her.
Asha, are you there?
Ma'am, I'm here, ma'am. Good morning, ma'am.
I think they all are having problem logging in.
Srishti is host. I think she can allow the Dr. Srishti or Srishti. I think she can allow.
Nilima, are they all doing it from the mobiles, not the laptop?
We'll have to tell them to log in from the laptops. That will not do from the.
Everyone can send to.
Otherwise, they will have to send to Srishti.
Ma'am, can I share my screen, ma'am?
Sure. Who's Yapi speaking? Yeah.
No, ma'am. I'm Asha Saxena, ma'am.
Come on.
Okay, yes. Asha, yeah, you can start, please.
Miss Asha Saxena?
Yes, ma'am. Can I start, ma'am?
We cannot see you.
We cannot see your screen yet. It is coming as you're sharing the screen, but your screen is not visible yet.
Asha, are you using your laptop?
Yes, ma'am. I'm doing with my laptop.
The slides are not visible. Sorry.
Miss Asha Saxena, can you just go back to the slide mode and then again go to slideshow mode?
Yes, ma'am.
Selection party moderator absent tonight.
I request the other participants to meanwhile just log out and again check your Zoom meeting with sharing the screen with some other participants so that it is on board. Everything is on board.
I think Dr. Babita Gupta has entered.
Yeah. If Asha is not sharing her slide, I can share Dr. Babita's slide and we can introduce her.
Miss Asha,
Welcome,
if you
Dr.
can just
Babita.
stop sharing and we'll have Dr. Nilima to share her screen.
Okay, ma'am. Okay, ma'am.
Asha, you stopped sharing your slide?
Yes, ma'am.
You've stopped it?
Yes, ma'am.
No, not yet.
Not yet. Yeah, Dr. Neelu.
Yes.
This is
welcome, Dr. Babita. She's the consultant in charge of Gynae Department, Endoscopic Surgery, Pushpanjali Hospital, Agra, ex-professor at FHSMC, Government Medical College, Firozabad. She's our next judge. So welcome. Good morning.
Good morning, Dr. Babita. Welcome for the session. And I think we can now, who was sharing the slide?
Asha, are you able to share?
Yeah, I'll stop my slide share so that Asha can start with it. Asha, are you ready?
Is she able to start? She will ask you.
तो 11 बजे मीटिंग चल रही है.
Yeah, we can see the slide now.
So you can start now.
Can I start, ma'am?
Yeah, please start.
A very good morning to all the respected teachers. Myself, Dr. Asha Saxena. I am working as a junior resident in Department of Obstetric and Gynecology, GSVM Medical College, Kanpur. Study the role of serum biomarkers combined with uterine artery Doppler in prediction of preeclampsia in primary gravidas at a tertiary care center. Pregnancy-induced hypertension affects 7 to 10% of all pregnancies, and it's a leading cause of maternal morbidity and mortality. In developing nations like India, where high-risk specialists are limited, the screening test to predict preeclampsia would be a powerful tool in pregnancy. Preeclampsia-induced mortality. Preeclampsia affects preeclampsia is a leading cause of maternal morbidity, especially when it occurs before 34 weeks. Hypertensive disorder of pregnancy occurs due to the various immunological factor and genetic factor. Pathogenesis comprises placental ischemia, oxidative stress, and other factors resulting in vascular anomaly, which leads to the inadequate trophoblastic invasion, leading to the increased resistance of uterine artery blood flow, which result into the functional decline leading to the hypoxic ischemic injury at the placental site, which leads to the local production of various polypeptide substance into the maternal circulation. The aims and objective was my study was to evaluate effectiveness of mean arterial pressure, uterine artery pulsatility index, and PAPIL level in the first trimester in the prediction of preeclampsia, to evaluate effectiveness of mean arterial pressure, uterine artery pulsatility index, and PLGF level in second trimester in prediction of preeclampsia, and to compare and evaluate effectiveness of combined first and second trimester screening strategies. Material and methods. My study was a prospective observational study, was conducted in the Department of Obstetric and Gynecology. The duration of study was 18 months. A patient who are willing to participate in the study, and all primary gravidas of age more than 18 years with singleton pregnancies attending OPD in the first trimester are taken into the inclusion criteria, and the patient who did not give consent of age more than 35 years and less than 18 years, multi-parity, multi-fetal pregnancy, molar pregnancy, patient with obesity with BMI of more than 35 kg per meter square, with history of smoking, patient of the chronic hypertension, chronic kidney disease, and patient with gross fetal anomalies was excluded from our study. After taking their proper written informed consent, enrollment was done. A detailed questionnaire was filled according to the patient particular demographic factor, past history, family history, and body mass index. After routine antenatal examination, the following parameters were recorded. Mean arterial pressure of each arm was calculated. The arm with the highest final mean arterial pressure was taken for the subsequent analysis of the result. Uterine artery Doppler was done in our department according to the ISUOG practice guideline. The pulsatility index of both right and left uterine artery was measured, and the mean PI of the uterine artery was calculated. Maternal serum sample for the testing was collected via venipuncture techniques. The sample was centrifuged for 15 minutes at the rate of 400 rpm, and the serum was stored in deep freezer at the temperature of minus 20 degrees centigrade and were analyzed by using PAPE and PLGF ELISA kit. Patients who were enrolled in our study were kept on follow-up. Patients were called for the antenatal visit every 2 weeks till 34 weeks and weekly thereafter. To recording of the systolic and diastolic blood pressure at least 4 hours apart in a previously normotensive women were considered. If hypertension developed before 34 weeks, then patient is classified into the early onset PT, and after 34 weeks, then patient classified into the late onset PT. The study continued till the optimal sample size is achieved within the given duration. Observation and result. This table is showing the association of mean arterial pressure, PAPE level, and UAPI with the development of early onset PET in first trimester at the gestational age of 11 to 14 weeks. Logistic regression analysis was used to assess the predictive power of mean arterial pressure, PAPE level, and UAPI to predict early onset preeclampsia. Coefficient for all three parameters was statistically significant. For PAPE, the regression coefficient, the p-value was 0.000 and the odd ratio was 111.1. This implies that if the low level of PAPE found in the first trimester, then the chances of early onset PET are at least 9.25 times more than otherwise. Also in case of UAPI, the p-value was found 0.007 and the odd ratio 46.305. This implies that if the value of UAPI increases in the first trimester, the chances of patient landing into the early onset PET is 2.8 times more than otherwise. This table is showing the association of mean arterial pressure, PLGF level, and UAPI for the development of early onset preeclampsia in second trimester at the gestational age of 16 to 20 weeks. The regression coefficient for mean arterial pressure in UAPI in second trimester was not statistically significant. The significance of PLGF level is found with p-value of 0.00 and the odd ratio of 0.028. This implies the level of PLGF is lowered in the second trimester, then chances of the patient landing into the early onset PET is 5 times more than otherwise in second trimester. Discussion. In the developing country with the limited access to the healthcare facilities, preeclampsia is still a major cause of maternal mortality and morbidity. Therefore, early detection or prediction of preeclampsia should be imperative, and non-invasive diagnostic methods like serum biomarkers, uterine artery Doppler to be used as a screening tool to detect it early. Our study showed that by using logistic regression analysis, mean arterial pressure, PAPE level, and uterine artery pulsatility index in first trimester show a statistically significant association between these parameters and the development of early onset PET. Studies show a statistically significant correlation between the PLGF level and early onset PET in second trimester, while mean arterial pressure and UAPI in second trimester did not add further information. In case of late onset preeclampsia, in first trimester, only level of PAPE was found, the decreased level of PAPE was found statistically significant, while other parameters in either in first trimester and second trimester did not add any other information regarding to the late onset PET. Therefore, on the basis of available data, we cannot conclusively say that late onset PET can be predicted by these above these variables. Conclusion. First trimester screening for preeclampsia will allow for a personalized risk estimate to the population early in their pregnancy. A combination model including maternal history, mean arterial pressure, uterine artery Doppler, along with the serum biomarkers, perform better than a single parameter in the prediction of early onset PET. Final conclusion drawn from our study that no single biomarker has alone its role in prediction of preeclampsia. The combination of these biomarkers with the mean arterial pressure and the uterine artery Doppler has the highest predictive value in the screening of early onset PET, but has only limited importance for the detection of late onset PET. Further, still large studies are needed to justify the introduction of these biomarkers into the routine practice for prediction of preterm preeclampsia. Very much.
Thank you, Dr. Asha. We have the judges
very much, ma'am.
with us. Madam, if you want to ask some questions for discussion, Dr. Vani, Dr. Babita. And Dr. Poonam is also there. Anybody?
Dr. Asha, I have one question for you.
Yes, ma'am.
Can you tell me what increases the cost for the combination of the biomarker and the mean arterial pressure? Cost of the patient.
Can you repeat your question, ma'am? Please, ma'am.
What is cost come in combination of the test with the biomarker for early onset of?
Ma'am, yes, ma'am. It was, ma'am. Actually, it was in the range of 2,000 to 250, 100, ma'am. But it was my collaboration to a private lab with discount level. Matlab, for one patient, it is around 800 to 1,000, ma'am.
Okay. It is not available in your institute right now?
No, yes, ma'am, not available.
Okay. Thank you.
Thank you, ma'am.
Asha, Dr.
Yes,
Asha.
ma'am. Yes, ma'am.
How did you look for the uterine artery pulsatility index in the first trimester? How was it recorded?
Ma'am,
And at what gestational age in the first trimester?
Ma'am, in the first trimester, ma'am, 11 to 14 weeks.
How did you assess at 11 to 14 weeks? What route? Abdominal, Lolina? 11 to 14 weeks?
Yes, ma'am. Yes, ma'am.
Is there any benefit of seeing it earlier than this? Did you do any intervention when you found that there was a deranged pulsatility index, blood flow was less? Was any intervention done?
Hello.
Okay. Thank you.
We'll call the next participant now. Dr. Neelu, please, ma'am, see if who's the next one. Is Yapi able to?
Hello.
Ma'am, Neelu, ma'am, please unmute yourself.
Hello, ma'am.
Yeah, who's there? Neelu, ma'am, please unmute yourself. Dr. Neelu. Dr. Neelu, ma'am, please unmute yourself. Who's the next speaker with us? Is Yapi ready with her slides?
Good morning, Dr. Nilima.
Yeah, who's speaking? I'll just go through it.
Now the participants are in the chronological order. Sudakshi Kinga didn't come up. Miss Yapi, are you ready with the PPT? If Dr. Yapi, then Dr. Fatima.
Good morning, Dr. Rehana. I can see you here. Welcome. Good morning, Dr. Rehana. She's muted. Dr.
Hello,
Neelu,
good morning, ma'am.
Hello, good morning.
Good morning. So, Yapi, are you there?
Hi.
Hello, everyone. Can you hear me?
Yes.
Hello.
Hello, Dr. Neelu. Hello, Dr. Rehana.
Hi.
And then Dr. Vani is there. Hello, Dr. Vani. Dr. Babita is there. Hello, hi everyone. And Dr. Poonam. We have all the four judges with us. Hi, Poonam. Hi. And rest are the speakers with us.
Meeting Dr. Rehana and Dr. Vani for the first time.
Yeah.
Welcome all of you to UPCOG 2020 first session of our the day and our conference.
Better.
Okay.
Dr. Yapi, are you able to share your screen? Dr. Fatima, are you there? Dr. Mrinalini?
Yeah, ma'am.
May I know who's this? Miss Asha Saxena, you can mute yourself.
Okay, ma'am.
Who's the next one who's coming to us with the slides?
Yapi, are you coming or Mrinalini?
Sorry, ma'am, I'm not able to share my PPT.
Okay.
Who's the next
Mrinalini,
speaker?
are you there?
Miss Fatima, Miss Mrinalini, Miss Anita Gond.
Mrinalini is also not there.
Miss Anita Gond.
Anita was there.
I can't see Anita right now. Okay.
I think they have all
Neha
must.
Sharma. Neha Sharma.
Yeah, Neha is there.
Yes, Neha is
Anjali
Neha
Pandey
Sharma?
also I can see.
Miss Neha Sharma.
Neha, are you there? Neha Sharma? Manjiri is also there. Manjiri, can you hear us?
Yes, ma'am.
Manjiri, are you ready with your slides?
Yes, ma'am. I'm ready.
Miss Manjiri,
Okay, so let
you will
Manjiri
have to
share her slides.
mute one of the system which is there.
Yes, ma'am.
Manjiri. See, I would request all the participants to please log in with your laptop or desktop, not with the phone. Yeah, Manjiri, yeah, we can see your slides. Very good.
Ma'am, should I?
Yeah, please start. Please start.
Unmute कर दो. कैसे आया?
वो आ गया है इसलिए अब उसमें
Thank you.
Good morning, ma'am. My topic for paper is, ma'am, effect of vaginal dosing with normal saline before insertion of dinoculation vaginal insert for labor induction. Ma'am, myself Manjri Pandey, Jayatri from KGMU Ops and Gynae Department. Prostaglandins have a dual action of cervical ripening and promoting uterine contraction in labor induction. Although it is clinically effective, wide variability has been observed in its efficacy. Vaginal pH has been suggested to be one causative factor responsible for variation in its efficacy. Vaginal dosing has been shown to alter vaginal pH and make it less acidic by reducing the density of normal vaginal flora, mainly lactobacilli, and washing out the acidic secretions present in vagina, and might increase the chances of successful induction of labor. Thus, vaginal dosing before gynecologist insertion may reduce chances of failed induction, rate of cesarean section, and related maternal and perinatal morbidity. Aim of my study was to evaluate the effect of vaginal dosing with normal saline before insertion of gynecologist vaginal for induction of labor. This study was conducted in Department of Ops and Gynae, KGMU Lucknow. Over a period of 1 year, it was a randomized control trial, and there were 45 cases in each arm. Inclusion criteria were singleton pregnancies with term, cephalic presentation, reactive fetal heart rate in cardiotography, no contraindication to vaginal delivery, absence of spontaneous uterine contractions, and cervical modified with subscore less than 5 were enrolled for this study. Exclusion criteria were multiple pregnancies, pregnancies less than 37 weeks, non-cephalic presentation, ruptured membranes or suspected chorionitis, non-reassuring fetal heart rate, fetal anomaly and fetal demise, emergency delivery indications, any known hypersensitivity to prostaglandins, and previous cesarean delivery or other uterine surgeries. Total 120 patients were assessed for eligibility. 30 patients were excluded on the basis of exclusion criteria. 90 patients were randomized into two groups, 45 cases in each group, study and control group. And study group is group A and control group is group B. In group A, before vaginal dosing with normal saline, vaginal pH was measured. Pre-dosing mean vaginal pH was 4.91. After measuring pH, dosing was done with 20 cc of normal saline, and again vaginal pH was measured, which was 5.52 in group A. After inserting nanopotion insert, delivery outcome were noted in terms of vaginal delivery or cesarean section. In group A, 34 patients had vaginal delivery and 11 patients had cesarean section. In group B, without vaginal dosing, dinopotion vaginal insert was inserted, and in this group, mean vaginal pH was 5.0. Total 31 patients in group A had vaginal delivery and total 14 patients had cesarean section. Primary outcome was measured in terms of duration from the beginning of intravaginal danopost administration to the active phase of labor, and secondary outcomes were change in vaginal pH after dosing with normal saline, duration from the time at intravaginal insertion to full cervical dilation, route of delivery, presence of uterine hyperstimulation, presence of labor arrest, fetal distress, meconium discharge, or any fetal infection. Details of vaginal pH in two groups. In group A, mean initial vaginal pH was 4.91 and after dosing it was 5.52. In group B, mean vaginal pH was 5.0. This is a scatter diagram of distribution of vaginal pH in both the groups. Change in Bishop score after removal of dinopotion vaginal insert in group A and group B. In group A, mean initial Bishop score was 2.51 and in group B it was 2.73. After removal of dinopotion insert, it was 7.67 in group A and 7.36 in group B. Comparison of duration of labor between two groups. In group A, total time from dinopotion insertion to active phase of labor was 18.31 hours and in group B it was 19.38 hours. In group A, time to complete cervical dilation from dinopotion insertion was 21.26 hours and in group B it was 22.91 hours. Duration of second stage of labor in group A was 1.04 hours and in group B it was 1.13 hours. Comparison of duration between dinopotion pastry insertion and delivery in two groups. In group A, in between primary gravida, total duration was 24.64 hours and in group B it was 29.13. Whereas in multigravida in group A, total duration from dinopotion insertion to delivery was 19.29 hours and in group B it was 19.02 hours. Comparison of mode of delivery. In group A, total 75.56% patient had vaginal delivery and in group B, total 68.89% had cesarean section. In group A, total 24.44% of patients had cesarean delivery and in group B, it was 31.11% had cesarean delivery. P-value was insignificant. Comparison of initial vaginal pH with mode of delivery in overall patients. It was seen that patients who had delivered vaginally had mean initial vaginal pH 5.1, and in patients who had cesarean section had mean initial vaginal pH of 4.63. Ma'am, this p value here, p value was significant. Complications in group A, in group A and group B, both total three patients had hyperstimulation. In group A, 8 patients, and in group B, 6 patients had acute fetal distress, and in group A only 1 patient developed fever. Conclusion: there was significant increase in the vaginal pH using with normal saline. 4.91 versus 5.42. Main intrinsic vaginal pH, that is pH before inserting dinopostoral insert in women who delivered vaginally, was significantly higher than the women who had cesarean section. That is 5.10. P-value was less than 0.001. Time interval between dinopostoral insertion, active phase of labor, duration of active phase of labor, time interval between dinopostoral insertion and complete cervical dilation were not significantly different in two groups. Thank you, ma'am.
Any questions from the judges?
The vaginal
Manjari, what was the rationale of your study?
Ma'am, it is seen in several studies that vaginal dosing increases the vaginal pH. Ma'am, it is seen that with increase of vaginal pH, chances of successful induction labor has been increased. there is no study in which we can increase the pH. Ma'am, this is the first study from India in which we have used vaginal dosing with normal saline, which can improve the vaginal pH. But ma'am, no significant difference was seen. But one significant point was here that measuring initial vaginal pH, by measuring the initial vaginal pH, we can conclude that higher vaginal pH, patient with higher vaginal pH have more chances of successful labor induction.
In comparison to the control group, was the pH more in the study population?
Mean initial pH was, ma'am, not significantly different between two groups, but after dosing in group A, which was a study group, vaginal pH was significantly increased.
Was this within the study and the control group that the difference was significant, or in comparison between the two groups also it was significant? Do you get my point?
Yes, ma'am.
Between study and the control group, was the pH significantly different between the two?
After dosing, ma'am, in group A, pH was significantly increased.
In comparison to?
Group B, ma'am, control group in which vaginal dosing was not done.
Okay, thank you.
But you were saying no statistical difference was found, na?
Yes, ma'am. It was, ma'am, because vaginal pH, which is increased, is only for few hours, ma'am. It is found in some studies that vaginal dosing increases the pH only for few hours. So again, acidic pH, which is normal vaginal pH, is increased, ma'am, after a few hours. Because lactobacillus, main bacteria is responsible for vaginal pH regrows.
Okay. And in your patients, all those who were induced, they were not having any ruptured membranes or bleeding.
No, ma'am. No, ma'am. It was in exclusion criteria.
What was the indication?
It was not a randomized trial, na?
Ma'am, it was a randomized trial.
What type of study it was? Huh?
Ma'am, randomized control study, ma'am.
Did you tell
You have not told anything about randomization?
Ma'am, randomization
in your
was done
study?
with yes, ma'am. Ma'am, randomization
How you
was
have
done
done
with
the randomization?
ma'am, computer generated numbers, ma'am.
Okay, that you have not mentioned in your methodology slides.
Okay, sorry, ma'am.
Chalo, I think we finish up. And can we have the next time?
What was the most common indication of cesarean, or the cesarean indications were related or unrelated to induction?
Ma'am, most common indication was cholestasis in both the groups, ma'am.
What?
Cholestasis, ma'am.
Cephalopelvic disproportion?
No, ma'am. Cholestasis, ma'am. Ma'am, pregnancy-induced intrahepatic cholestasis.
Was the indication for cesarean?
No, ma'am. No, cesarean. Not for cesarean, ma'am. Saying, ma'am, for cesarean, it was, ma'am, NRNST, ma'am, category 3 CT.
We can call the next speaker, ma'am, Dr. Neelu, please.
Yes, Yapi, are you there? Otherwise, we can call Mrinali Singh.
Miss Mrinalini Singh, are you there?
बीच में ये वाला इंटरनेट जो है ना वो अनस्टेबल हो जाता है मेरी.
Miss Fatima Osami.
Anita Gaur.
Hello, Dr. Nilima, is there a problem of connection?
मेरे में ये कि मैं नहीं मेरी स्लाइड
Neha Sharma.
Ruchi Pandey.
Yes, ma'am, I'm here. Ruchi Pandey.
Ruchi, you can join in.
Yes, ma'am.
Who's? Yes, this is Ruchi. Come on.
देखो मेरी स्लाइड मेरा देखो
Ma'am, is it visible?
Yeah.
Okay, thank you, ma'am. Good morning, ma'am. Myself, Ruchi Pandey, JR3 Department from Department of Ops and Gynae, KGMU, Lucknow. My topic is Association of Serum Ferritin Level in Early Second Trimester of Pregnancy with Development of Gestational Diabetes Mellitus in North Indian Population. As we know that hyperglycemia is one of the most common medical condition women encounter during pregnancy, and it is a leading cause of maternal morbidity, perinatal morbidity, and neonatal morbidity. The prevalence of GDM worldwide is 15 to 20%, and in India it is 10 to 14.3%. Serum ferritin is a major storage protein of iron. It also acts as acute phase reactant, which increases in inflammatory conditions. GDM is a state of insulin resistance, and it is also associated with inflammation. The aims and objective were to find the level of the serum ferritin in normal pregnant women and in women with GDM, and to find out the correlation between serum ferritin level with subsequent development of GDM. My study was a prospective observational study conducted in Department of Ops Gynae KGMU in collaboration with Department of Pathology, and singleton pregnant women with 14 to 20 weeks of gestational age were included in the study. And with exclusion criteria, anemia, patients who develop gestational diabetes mellitus before 20 weeks of gestation, preeclampsia, type 1 or 2 diabetes, any hematological disorder, any autoimmune disorder, or any inflammatory disorders. Total 302 pregnant women attending antenatal clinic between 14 to 20 weeks of gestation were examined and advised antenatal investigations. Simultaneously, 2 ml of blood sample were collected in plain vial for serum ferritin assay. Thereafter, all the women were called between 24 to 28 weeks of gestation for blood sugar screening by DIPSI method. Out of 302 pregnant women, 92 women whose blood glucose level more than or equal to 140 milligram per deciliter were labeled as study group, that is GDM, and as 210 pregnant women with blood glucose level less than 140 milligram per deciliter were labeled as control group, that is non-GDM. When it comes to result, total 30.5% of the pregnant women were GDM and 69.5% pregnant women were non-GDM among 302 pregnant women. Comes to demographic profile, in age, habitat, and socioeconomic status, both the group were comparable, but no significant difference were found between the two groups. In dietary habitat, women with GDM has the higher proportion of non-vegetarians, but the difference was not found statistically significant. And in GDM group of women, the mean BMI was higher as compared to non-GDM, and this was statistically significant. Then serum ferritin level in two groups. The group 1, that is GDM population, had mean serum ferritin level 56.44 with standard deviation of 19.19, and in group 2, that is non-GDM, mean serum ferritin level was 27.62 with standard deviation of 12.11, and this difference was found statistically significant. In the table, we can see that with increasing blood sugar level, that is done by DIPSI method, the mean serum ferritin level is getting increases. That is, if blood sugar level is more than 180 milligram per deciliter, the mean serum ferritin level reaches 68.54 nanogram per ml. And this difference was found statistically significant. ROC curve was drawn, and the cutoff value of the serum ferritin was calculated, which is more than 37.55 nanogram per ml, with a sensitivity of 85.9% and specificity of 81.9%, with positive predictive value 67.5% and negative predictive value 93%. So, in conclusion, women with GDM have higher BMI as compared to non-GDM, and no significant difference have observed in terms of age, habitat, dietary habits, and socioeconomic status between two groups. And the mean serum ferritin level in the study group, that is GDM, 56.44 nanogram per ml, was found significantly higher than in control group, that is 27.62 nanogram per ml. So more such studies needed to find a strong association between serum ferritin and gestational diabetes mellitus, so that making is as a tool for the early diagnosis of GDM. Thank you, ma'am.
Questions from the judges, please.
In what kind of a population is this test a limitation?
Sorry, ma'am.
In what kind of a population, pregnant population, will this test be a limitation?
Ma'am, anemia was this exclusion criteria, and the pre-diabetic women or women who had pre-eclampsia or any inflammatory disorders, they were excluded.
So what do you think its role in India as a screening test to predict GDM? What do you think?
Ma'am, if non-anemic women will be included, then this will be benefited.
Any more question? Okay, can we go to the next candidate?
Ma'am, I just want to announce one thing, that the candidates who are not able to log in, please, Srishti, can they have your number or something so that they can send you the slides? Otherwise, there are some people who are not able to log in. Yapi is one of them.
Yapi, ma'am, if they are logging in through their phones, they won't be able to share the PPTs, and that is the only thing.
Yeah, so that is what I want, that if you can announce your phone number, they will send you the PPTs or they will mail you the PPT.
Okay,
And
I am just dictating my email ID for everyone. Okay, everyone just make a note. If at all, in case of extreme emergencies like Yapi, we'll share the screen. Okay.
Yeah.
My email ID is. I'll just put a message over here in the chat box for everyone.
Yeah. Please, anybody who's not able to log in, please send your slides to Srishti. Okay. And who's the next speaker now?
Mrinalini Singh.
Mrinalini Singh is not there yet.
Anita God.
Hello?
Anita was there.
Anita was there. I saw Mrinalini also.
Ma'am. Hello, hello, ma'am.
Yeah,
Anita, are you there?
Morning, ma'am.
Yeah,
Mrinalini, you are there?
Yes, ma'am.
Come on, you can start.
Ma'am, am I audible?
Yeah. Share your screen.
Yes, ma'am. Ma'am, you have to enable the participants.
Yeah, I'm doing that. May I know who's
Mrinalini, ma'am.
Mrinalini, you are logged in by a different name?
No, ma'am. I'm logged in with Mrinalini only, Mrinalini Singh.
Yes, you can share the screen now.
Ma'am, is my screen visible?
Yeah, we can see.
Should I start my presentation?
Yeah, please do.
Just a minute. Good morning. I'm Dr. Mrinalini Singh, a junior resident, Department of Obs and Gynae, JSPM Medical College, Kanpur. The topic for my paper presentation is evaluation of platelet count and mean platelet volume to predict the risk and prognosis of preeclampsia. As we all know, preeclampsia is an intractable obstetric disorder affecting 2 to 8% pregnancies globally and 8 to 10% pregnancies in India. It has high perinatal and maternal mortality and morbidity rates. Preeclampsia is defined as hypertension with or without proteinuria, hypertension when systolic BP is more than equal to 140 mmHg or diastolic BP more than equal to 90 mmHg, measured on 2 occasions at least 4 hours apart after 20 weeks of gestation in a woman who is previously normotensive. The aim of my study was to evaluate platelet indices, platelet count, mean platelet volume as a potential predictor for the onset of preeclampsia, and to compare platelet count, mean platelet volume in non-severe preeclamptic, severe preeclamptic, and healthy normotensive pregnant women to evaluate whether these parameters have a prognostic significance in determining the severity of preeclampsia. Why platelet indices? Platelet indices are inexpensive and they can be measured by a routine blood count. Platelet functions are indirectly measured by calculating these indices like mean platelet volume and platelet count. Mean platelet volume measures average size of the platelet. It increases or decreases depending on the severity of inflammatory response. It indirectly reflects platelet activity, while platelet count measures average number of platelets in a blood. My study was a prospective study conducted to predict and evaluate the role of platelet indices in preeclampsia in antenatal outpatient department of Obs and Gynae, GSV Medical College, Kanpur, for a duration of 20 months. Inclusion criteria was a pregnant woman of age 18 to 45 years at 20 to 24 weeks of gestation, and patient with either mild preeclampsia, severe preeclampsia diagnosed according to ACOG. Exclusion criteria was women with previous pre-existing renal disease, insulin-dependent diabetes, chronic hepatitis, severe trauma history, smoking history, ITP, health syndrome, gestational thrombocytopenia, or any other hematological disorder. It was her demographic details were taken, and BP was taken by auscultatory method, and then at monthly interval, CVC was done from 20 to 24 weeks till 40 weeks and 7 days after delivery, and then the patient was followed till delivery. Patient that was analyzed was 120, out of which 26 were lost to follow-up, and remaining 94 patients, 16 developed preeclampsia, giving incidence of 17%. This can be seen with this pie chart. This table shows comparison of change in platelet count amongst normotensive severe preeclamptic patient, non-severe preeclampsia. This demonstrates the decrease in platelet count with gestational age when counts at monthly interval from 20 to 40 weeks was compared. For normotensive, it was 0.18. For non-severe PT, it was 0.31. And for severe preeclampsia, it was 0.62. Using analysis of variance, the p-value was less than 0.01. That was significant. Now, as thrombocytopenia depends upon the intensity of disease, and decrease in platelet count was an early feature and was directly proportional to severity of the disease. Hence, when month-wise estimation was done, this decrease in the platelet count was more as severity of disease increased, as can be seen from this line diagram. This table shows the comparison of change in mean platelet volume amongst normotensive, non-severe preeclampsia, severe preeclampsia. This demonstrates that mean platelet volume increase with the gestational age when counts at monthly interval from 20 to 40 weeks was compared. For normotensive, it was 0.89. For non-severe preeclampsia, it was 3.67, while for severe preeclampsia, it was 4.7. We observed that there was significant increase in mean platelet volume in preeclampsia with the duration of gestation as BP increased. This increase was more significant as the severity of preeclampsia increased. So increase in mean platelet volume is directly proportional to the severity of disease, and that can also this can be seen in this line diagram. Now this table shows the correlation coefficient between the platelet count in normotensive non-severe preeclampsia and severe preeclampsia, and correlation coefficient for the normotensive is 0.58, for non-severe PT is minus 0.59, and for severe preeclampsia is minus 0.94. A negative correlation was seen between the blood pressure, platelet count, as And as the BP is increasing significantly, correlation coefficient is decreasing, and it was lowest in the patient with severe preeclampsia, as can be seen with this line diagram. This table shows the correlation coefficient between the mean platelet volume in normotensive, non-severe PT and severe PET. Correlation coefficient for normotensive was 0.89, for non-severe PT it was 0.97, and for severe PT it was 0.98. A positive correlation was seen between the blood pressure, mean platelet volume, and as BP increased significantly, correlation coefficient increased, and it was highest in the patient with severe preeclampsia. So to conclude, platelet count has negative correlation while mean platelet volume has a positive correlation with increase in blood pressure. Estimation of platelet indices can be considered as early, economic, and rapid procedure of assessment of severity of preeclampsia. Therefore, platelet indices is a cost-effective investigation and can predict the risk and prognosis of preeclampsia at much earlier gestation age. Thank you.
Good. Any questions from the judges?
Hello, Dr. Manjari. Hello. Hello. Hello.
Yes, ma'am.
Hello. Have you fixed any cutoff for the platelet count, as the normal platelet count has a wider range? Have you decided any cutoff lower level?
No, ma'am, in my study, the cutoff was not there. It was only for the prediction of preeclampsia. So, with the decrease, we were predicting that it is going towards
not fix the cutoff. In selection of the patient, you don't have the cutoff level.
No, ma'am. The decrease in the we were just estimating with the blood measuring.
You don't have any cutoff value of the
monthly interval.
Normal value.
Yes, ma'am.
He's asking the cutoff value.
Yeah.
Ma'am, normally it is thrombocytopenia when it is 1 lakh, less than 1 lakh.
So you have ruled out gestational thrombocytopenia. I'm not talking about the thrombocytopenia. In normal platelet count, there is a wide range. So, if are you decided fixed any cutoff value for normal range?
Ma'am, in my study, I have not fixed any cutoff range for that. It was mainly a prospective study. Okay. Her BP and her platelet was measured at a regular interval, that is at a monthly interval. In 4 weeks, her sample was taken. So, okay. It was just the trend that we could see, the decreasing trend of the platelet with the rise in the BP.
Okay. Have you measured the PC to MBP ratio?
No, ma'am, the ratio I have not taken.
More significant is the platelet count to the platelet volume ratio, mean platelet volume ratio. That is more significant. Okay. Thank you.
Manjari, can I ask you something else? With the BP, can you tell us, say, BP 150, 100, what was the platelet count, or were you able to observe that?
Yes, ma'am, that is there. Just a minute.
What was the lower limit you reached?
Ma'am, let me show it to you on my slide. Can I share my slide, ma'am?
I think, ma'am, we are running short of time.
Yeah, then we can go to the next. Is the next speaker ready? Anita God?
Yes, ma'am. Yes,
ma'am. Anita, you're there?
Yes, ma'am.
Yeah, you can start. Share the screen.
Yes, ma'am. Good morning, ma'am. Ma'am, I'm Anita Gond, Junior Resident, Department of Obs Gynae, GSP Medical College. My paper topic is a comparative study to evaluate efficacy, safety, and fetal-maternal outcome of intravenous pericarboxymaltose versus oral ferrous ascorbate for iron deficiency anemia during pregnancy.
Sanvi. Mute. Mute.
Introduction. Anemia is a global public health problem. It accounts for 40% of maternal death in developing country, out of which it is responsible for 25% of host start can direct maternal cause. The prevalence of iron deficiency anemia in pregnancy in India range from the 23.6% to 61.4%. Beside maternal mortality it also caused increased perinatal mortality and morbidity, although it is a major preventable cause of unfavorable perinatal mortality and morbidity. Next.
What happened?
Ma'am, slide.
We can see the slides. Yes.
Parenteral iron therapy is a upcoming effective alternative to oral iron preparation. FCM have been developed recently. Its property like near neutral pH, physiological osmolarity, and increased bioavailability. It has very low immunogenic potential and therefore not predisposed to anaphylactic reaction. Aims and objective to find the feasibility of IV FCM over oral ferrous ascorbate to evaluate and compare efficacy, safety, and tolerability of IV FCM versus oral ferrous ascorbate in iron deficiency anemia in pregnant women, to compare the fetal-maternal outcome between oral ferrous ascorbate and the IV FCM. Method and material and a method. This study was conducted in Department of Obs Gynae, Upper India Sugar Exchange Maternity Hospital, GSP Medical College. Subject antenatal patient with hemoglobin range 7 to 10.9 gram per dl, irrespective of parity. My study is prospective interventional randomized clinical trial. Inclusion criteria: antenatal patient within 16 to 32 week of gestational age, hemoglobin level between 7 to 10.9 gram per dl, serum ferritin less than 30 nanogram per ml. Exclusion criteria: less than 30 weeks periods of gestation, intolerance of oral iron preparation, history of APH or recent blood transfusion, history of any disease like thalassemia, hemoglobinopathy, multiple pregnancy, hypersensitivity to iron preparation, or history of chronic illness. Methodology: written consent of patient was taken in standard form. The patient attending in our OPD of Obs Gynae department. Sahali's method was used to know the baseline hemoglobin. Total 235 antenatal patients were taken with hemoglobin 7 to 10.9 gram per dl. Then further divide into preventive group and a therapeutic group. Preventive group with hemoglobin 9 to 10.9 gram per dl. Therapeutic group 7 to 9 gram per dl. Preventive group randomized and divided into two groups. Group 1A and 1B. 1A treated with 100 mg elementary iron of ferrous ascorbate. 1B treated with single dose of 1000 mg single dose of FCM. Therapeutic randomized and divided subgroup in two group. 2A treated with 200 elementary iron of ferrous ascorbate, and group 2B treated with FCM in calculated dose. Then follow to this patient first week, third week, 6th week of post treatment and till delivery. On day 1, hemoglobin, reticulocyte count, red cell indices, serum ferritin, peripheral blood smear was done on first week of post treatment to assess the reticulocyte count, on third week of post treatment to assess the hemoglobin, MCV, MCH, MCSC, on 6th week of post treatment to assess the hemoglobin, MCS, MCV, MCH, MCSC, serum ferritin level. And these patients followed till the delivery and assessed fetal-maternal outcome. Iron dose calculation, iron and total iron deficit pre-pregnancy body weight into hemoglobin deficit into 2.4 plus 1000 element iron storage. This table show the mean rise. This table show the general characteristic of my subject. Majority of patient belong to age group 20 to 29. Mean age of gestation 22 week 2 days. Multi gravida more prone to iron deficiency anemia. Majority of patient belong to rural residents. More number of patient had primary level of education. This table show the comparison of two group of FCM and ferrous ascorbate of preventive group according to result. Mean rise in reticulocyte count in group 1A 0.23%. Mean rise in reticulocyte count in FCM is 0.7% after 1 week of treatment. Mean rise hemoglobin after 34 to 37 week of period of gestation 2.771 gram per DL after 34 to 37 week of pregnancy. 3.01 gram per DL raised in group 1B.
Anita, please wind up. Your time is over. It's already 6 minutes.
Yes, ma'am. Ma'am, minor side effects were noted. 2.7% of antenatal patient in IV FCM group, while 50% of antenatal patient in oral ferrous ascorbate. No major side effects were noted, making both iron compounds safe in pregnancy. Conclusion: in our study, IV FCM were found more efficient than oral ferrous ascorbate, statistically highly significant. We concluded that IV FCM safe, effective, and tolerable in increasing hemoglobin level in pregnant women with iron deficiency anemia in second and third trimester. We can propose the addition of IV FCM in ongoing program of India reducing iron deficiency anemia during pregnancy. Thank you, ma'am.
Any questions from the judges? One or two questions. If no questions, we can go to the next one.
In your selection patient. Hello.
Yes.
Yes.
Yes, ma'am.
I think Dr. Babita, you have to unmute you.
Dr. Anita, are you getting me?
Yes.
Have you considered the socioeconomic criteria while selecting the patient in this group study?
Yes, ma'am.
Anita?
Ma'am.
Hello? Anita?
जी मैम. जी
Hello?
मैम. हेलो.
तो अपने लिखो ना. अनीता?
जी मैम.
अपने स्टूडेंट में आपने कुछ सोशियो इकोनॉमिक ग्रुप कंसीडर किया है? लाइक कंसीडर किया है?
रैंडमली पेशेंट को लिया है ओपीडी से मैम, जिसका हीमोग्लोबिन 7.
वेजिटेरियन नॉन वेजिटेरियन ये सब सिलेक्शन क्राइटेरिया में नहीं थे?
नो मैम.
ओके. LASA, that is linear, LASA, that is fatigue.
बीच में हमारे
LASA, have you studied LASA in patient?
Yes, ma'am.
Improvement of, you study the symptomatology like LASA, that is improvement in fatigue and the quality of the life.
Yes, ma'am. मैम बस मैंने मैम बस इन्वेस्टिगेशंस कराए थे और सिम्टोमेटिकली ऐसे ओरली पूछा, मैं मेंशन नहीं किया है.
This is very important. Fatigue and poor quality of life is very, very important symptom in this anemic patients.
जी मैम.
So quality of life and fatigability, whether these symptoms are improved or not.
Improve हो जाते हैं मैम.
Right. So there is particular scale.
के बाद improve हो जाते हैं.
There is a linear analog scale, that is LASA. You are not included in this study. Okay.
No, ma'am.
So many things. Oco infestation in that area or any associated, blood bleeding disorders. Okay.
Ma'am, Exclusion criteria, bleeding disorder.
Okay.
Okay, can we go to the next candidate? I can see Yapi. Yapi, can you share your screen?
Miss Yapi, you have to choose a tab that is a PPT tab for sharing the screen.
Next one.
Yapi. Nazia Khan.
Miss Yapi, you have to select, when you select share screen, there will be multiple tabs, out of which you have to select your PPT tab for sharing the screen.
You can ask for Neha Sharma. You can ask for Nazia Khan.
Nazia Khan. Janti Chauhan.
Yes,
Nazia,
ma'am.
you're there?
Yes, ma'am.
Chalo, be ready and share the screen.
Yes, Nazia is there. Nazia Vasanti.
Miss Yapi.
Nisha Gautam. She's also there.
Yeah, Nazia, we can see your screen.
Ma'am.
Yeah, you can start.
Good afternoon, ma'am. The topic of my presentation is estimation of vitamin D25 hydroxy level in pregnant female with gestational diabetes and its correlation with non-diabetic pregnant women. Myself, Nazia, resident in Department of Obstetrics and Gynecology, KGMU. Chief Supervisor, Professor S.P. Jaiswal. Gestational diabetes mellitus is a condition in which pregnant female loses the ability to tolerate glucose. There are progressive changes in carbohydrate metabolism, which leads to elevated glucose level, and subsequently symptoms of diabetes develop. Gestational diabetes mellitus is affecting 10 to 14.3% of pregnant women in India, according to MOHFW 2018. Whether vitamin D supplementation in pregnant women can reduce the risk of developing GDM and reduce adverse pregnancy outcome in women with GDM remains unproven. There is a high prevalence of vitamin D deficiency, and with the increasing prevalence of gestational diabetes, especially in India, there is a need to evaluate the association of GDM with vitamin D deficiency. Our aim was estimation of 25 hydroxy vitamin D level in maternal blood in pregnant women of 24 to 28 weeks of gestation with gestational diabetes, and to find out its correlation with non-diabetic pregnant women. It was a prospective case control study conducted on 100 pregnant females in 24 to 28 weeks of gestation in Queen Mary's Hospital, and duration of study was 1 year. Assessment of gestational diabetes was done using 75-gram glucose load in non-fasting state, DIPSI criteria, diabetes in pregnancy study group of India. 25 hydroxy vitamin D level was estimated by chemiluminescent microparticle immunoassay method. Of the pregnant women who are coming in 24 to 28 weeks, assessment of GDM by DIPSI criteria was done, and measurement of 25 hydroxy vitamin D level. The sample was taken in red vial, 2 ml sample, and it was taken to pathology lab for vitamin D estimation. And the patients were divided into GDM and non-GDM, and they were compared according to vitamin D level. The inclusion criteria was patient giving written and informed consent, and all the 24 to 28 weeks of gestation that had normal fetal development in ultrasound with respect to their LMP or ultrasound confirmation were included. In exclusion, it was multiple pregnancy, women with pre-gestational diabetes, fetal abnormality, any chronic disease, hypertension, or history of consumption of convulsant drugs. In results of the comparison of age between the GDM and non-GDM patient, difference in mean age was found to be statistically significant. For GDM, the age was 28 and non-GDM was 26. The p-value was 0.032. In the comparison of BMI, the mean BMI was significantly higher in GDM group. Mean was 26.03 as compared to non-GDM, which was 24.24, which was also statistically significant. On the criteria of positive family history of type 2 diabetes, GDM patients were significantly more in number. And similarly, if the patient had a history of GDM previous pregnancy, their number was also more in GDM patients. Comparison of vitamin D between two groups, the mean level of 25 hydroxy vitamin D was higher in non-GDM group. Mean was 16.88 as compared to GDM group, which was 13.79, but it was not statistically significant. Of the 100 pregnant females who were taken, vitamin D sufficiency, that is vitamin D level more than 32 nanogram per ml, was seen in only 4% of the patients and none in GDM cases. Findings from our study suggest that sunshine vitamin is very commonly deficient in pregnant females at 24 to 20 weeks of gestation, but we did not find any evidence of its association with GDM.
Okay, questions from the judges.
तो 3 मिनट का आइडिया था, उसने 2.5 मिनट में खत्म कर दिया है.
अच्छा.
Why you have can you hello, can you hear me?
Yes, ma'am.
Yes.
Yeah, can you explain me why you have excluded come to the slide on exclusion criteria?
Yes.
You have excluded patients with anticonvulsant drugs. Why? Am I audible?
Yes, ma'am.
Yes.
In your exclusion criteria, you have written history of consumption of anticonvulsant drugs.
Yes, ma'am.
Why you have excluded them? Do they interfere with vitamin D3 levels?
Ma'am,
even hypertension, chronic disease. I just want an explanation why you have excluded these people.
Pregnancy was taken, multiple pregnancy was not taken. Then
multiple pregnancy I can understand, but for the other things. Okay.
Probably you are excluding the comorbidities, right?
Yes, ma'am. Other chronic diseases, preeclampsia and hypertension was excluded.
लेकिन your study is an observational study, है ना? You are not looking into the feto-maternal outcome.
No, ma'am.
Comorbid conditions will affect that.
Yes, ma'am.
I don't think so there is any association with vitamin D3 levels. Or there is some association. Do you know?
No, ma'am, not with vitamin D level.
No, it was an observation. You might have a subgroup with chronic diseases. Your study would have been much better then. And you have estimated vitamin D3 levels at what period of gestation?
24 to 28 weeks.
Okay, single estimation.
Single estimation.
Okay.
Any more questions? Can you go to the next speaker?
Who's the next speaker?
Next speaker, Yapi, are you able to join? Otherwise, Vajanti, Nisha Gautam. Vajanti Chauhan. Nisha Gautam.
Yes,
Yes. Are we
Nisha,
seeing
you're
the
there?
This is Yapi's slides?
ma'am.
Okay, Yapi is able to slide share.
Yapi.
हाँ,
Let's
चलो।
give her that.
Miss Yapi, may I request you to put it on the slideshow mode and then we can start the session? Thank
Yeah.
you.
Ma'am, can I start?
Yeah,
Yeah, please start.
Thank you, everyone. Thank you, ma'am, so much. Sorry for delaying. First of all, thank you for. Good morning, ma'am. Today I'm going to present a paper on a study of nutritional status of urban antenatal women of Kanpur.
Try to be a little louder.
Okay, ma'am. A study of nutritional status of urban antenatal women of Kanpur city visiting to our hospital. Here, to begin with, nutrition during pregnancy is an important factor which is associated both with maternal and infant health outcome. Hello. It's an
Yes,
important
Yapi.
factor of human fetal growth.
Louder, please.
See, ma'am. It has the significance of maternal nutrition is because it optimizes the pregnancy outcome, and it is an amenable to modifiable change, unlike other non-modifiable factors. And poor maternal nutrition results in a low birth, and in fact, low birth weight is associated with infant morbidity and mortality. And pregnancy is a period of dynamic changes as the fetus is nourished directly by the mother through the placenta, and a growing fetus needs more nutrition to meet the requirement. A proper diet balance is necessary to ensure sufficient energy intake for adequate growth of without compromising others on. And here with some studies like Sova Rao Isai, in their prospective study, they have found that intake of micronutrients as an important factor in a fetal growth in undernourished community. And similarly, Tona Zema, in their community-based cross-sectional study, they have found that poor dietary diversity, poor nutritional knowledge, poor dietary practice, poorly perceived self-efficacy were positively associated with undernutrition. And similarly, Derezi, in their community-based cross-sectional study, high which were associated with and economic status. We have come forward with my aims and objectives where assessment of nutritional status of urban ANC women of Kanpur visiting to our and to plot a dietary deficiency or excess my study is a prospective observational study.
Yapi, speak little louder. Come to the nearer to the mic. We are not able to listen. Chalo, continue. Don't waste time.
Prospective observational study, Department of Obstetrics and Gynecology, GSM Medical College, Uttar Pradesh, where we have taken 60 patients from time duration of 2019 to October 2020. Ethical was taken from
Yeah, please just check your audio. You're not audible.
Yapi, there's some internet issue at your end, or else.
Nilim. Srishti, can you solve the problem?
Ma'am, I could, but since the internet connectivity from their side is unstable, so I can't even help in any of the ways.
Nilima, I think Dr. Madhu Singhal is joined. I can leave after this.
Sure, ma'am. No issues. Yeah. Yapi, if you're not able to continue, maybe we'll have to disconnect and call the next speaker because we cannot linger on with it. You can try again later on, right?
Janti Chauhan or Nisha Gautam.
There's Neha Sharma, Manjari Pandey, Ruchi Pandey.
Who's on chronology? Neha is on. I think Neha should start the presentation if she's there.
Okay, Nilima, I'm taking leave. Okay, bye.
Hello, good morning.
Judges. Okay.
Ms. Neha, may I also request?
Good morning. Good morning, ma'am. Should I start, ma'am?
Yeah, please start.
Okay.
I'll just announce next if Neha Pandey and Ruchi Pandey, if you're ready, just be ready. After Neha Sharma, it will be your turn.
Manjari is done.
मंजरी ने तो कर दिया, मंजरी पांडे ने
तो कर चुकी है।
हाँ
मृणाली भी कर चुकी है।
राम जी नाश्ता लगा दो।
Should I start, ma'am?
Yes.
Should I start, ma'am? Hello.
Yeah, please start, Neha, start.
Thank you, ma'am. A very good afternoon to all my respected teachers. I'm presenting my paper on the topic to study the acceptability, efficacy, and side effects of Antra for contraception. Myself, Neha Sharma, Junior Resident 3 at the Department of Obs and Gynae, GSVM Medical College, Kanpur. My guide, Dr. Nina Gupta, and co-guide, Dr. Shelly Agarwal. Population explosion is a major problem for the developing nation and is an obstacle for the social and economic development. This is nothing new. Keeping this in view, in 1952 only, Indian government has started with a family planning program, which was one of our very earliest program to be started. The current contraceptive prevalence.
We cannot see your slides, beta.
Neha, your slides
started.
Mama,
I started. Okay, Mama, okay, Mama, I'm rechecking. Ma'am, is there someone else is allowed to share?
Everybody. I think Yapi has not. Srishti, please help. I think Yapi has not stopped her slide sharing. Probably that is why Srishti, this thing she's not able to share.
I can't see anybody sharing the screen right now from my side.
Ma'am, is it visible now?
No. You have to click on share screen and then only it will come.
Same.
You have to choose a tab that is PowerPoint presentation and then it will come up.
On share screen, one participant can share at a time. It is coming.
Yeah, that is what you are the co-host. You can do anything right now in the screen. You can share the screen. I've given the permissions to everybody.
Probably Yapi has not this thing stopped sharing.
No,
now we can see. Yeah. Neha, we can see your screen.
Okay.
Please start.
Ma'am, now is
Neha, you have to enable editing. You have
to
click on enable editing and then click on slideshow and then start.
Okay.
I request everybody to be ready with the slides prior to the sessions. Yeah. Click on the enable editing.
Ma'am, is it available in that Zoom option only from where we are logged?
No, Miss Neha. You can click on enable editing. Yeah. There's a yellow column wherein you have to click on enable editing and then only you'll be able to put it on the entire slideshow.
Should I continue with this? If the slides are visible.
Yeah. Your slide is visible now to study the acceptability.
Okay, ma'am. Yes, ma'am. Yes, ma'am. Ma'am, should I start now?
Yeah. Yes.
A very good afternoon. A very good afternoon to all my respected teachers. I'm presenting my paper on the topic to study the acceptability, efficacy, and side effects of Andhra for contraception. Myself, Neha Sharma. I'm junior resident at the Department of Obs and Gynae, GSVM Medical College. On the left hand side, we can see that family planning new logo also. My guide is Dr. Neena Gupta and co-guide Dr. Shelly Agarwal. Introducing the topic, population explosion has been a major problem of the developing nation and is an obstacle for the social and economic development. And this is something new, nothing new. Keeping this in view, even in 1952, India has launched a national family planning program, and it was one of the earliest programs to be launched by the government. The current contraceptive prevalence is only 47.8%, and the unmet need for contraception is 12.9%. And this is according to the recent NFHS 4 data. And hence, long-acting reversible contraception was the need of our society. And so, Dimpa as Antra was an important option for family planning program. And keeping all this in view, in 2017, Government of India introduced Dimpa as Antra to meet the unmet needs of contraception under Mission Parivar Vikas. Antra is a progesterone-only injectable given deep intramuscularly every 3 months. One dose is 1 vial of 150 milligram aqueous suspension of Dimpa. It is safe, highly effective, and reversible. Safe as there are minimum side effect, effective as we can see further that the typical failure rate of Dimpa is only 0.3 per 100 women a year, and this is according to the reference manual of injectable contraceptive, which is released by the Ministry of Health and Family Welfare. It is a reversible method of contraception. Now coming to the mechanism of action of Dimpa, which is similar to any other progesterone-only contraceptive. It inhibits ovulation as the high level of progesterone suppresses further levels and hence leading to inhibition of ovulation. It thickens the cervical mucus, making the penetration of sperm difficult and prevents the normal buildup of the endometrial lining. Now coming to the side effects of Dimpa, the main side effects are confined mainly to the menstrual irregularities only, and that too most of the women complaints of irregular bleeding during the initial course followed by amenorrhea in the later on period. And this is accompanied by minor other side effects like weight gain, change in mood, sex drive, headache, dizziness, abdominal bloating, discomfort, and other some minor side effects which are patient specific only. Now coming to the aims and objectives of our study, the aim of my study was to assess the acceptability, efficacy, and side effects of Dimpa as contraceptive in the women of postpartum, post-abortal, and the interval period. These were the 3 groups which I had taken, ma'am. Now coming to the methodology, the present study was conducted as an OPD basis and admitted patient in the Department of Obs and Gynae at UISCMS, GSVM Kanpur, Uttar Pradesh. My duration of study was April 2019 to September 2020. A total of 300 women were counseled, out of which 141 actually turned up who were using Dimpa as contraceptive. The inclusion criteria in my study was all the women 18 to 45 years of age willing to use Antra as contraceptive after taking informed consent and explaining all the necessary benefits and side effects were included in the study. The exclusion criteria which we had taken was according to the WHO category 4 criteria, which were breastfeeding women less than 6 weeks postpartum, or a blood pressure more than 160 by 100 mmHg, or unexplained vaginal bleeding. At the first visit, the date of first injection was noted along with the baseline weight, blood pressure, and the menstrual pattern, or any other significant complaint. All these things were noted on a Dimpa card, and this card was used for the follow-up visits also further. Now coming to my observation and results. A total of 300 women were counseled initially, out of which there were 80 women in the postpartum group, 170 in the interval, and 50 in the post-abortal period. And as we can see, the maximum acceptability was found to be in the postpartum group, that is 55% accepted Dimpa as contraceptive, followed by in the interval group, and less in the post-abortal, that is only 40%. Now coming to the demographic distribution of the various parameters which we found in our study. To sum up this, a maximum number of Dimpa users which I had found were 26 to 30 years of age group, and the median age was 25 to 9.2 years only. Parity was maximum in the para 2 group, and maximum number of patients had secondary level of education. Maximum number of Dimpa users belong to lower socioeconomic status class 3 by the BJ Prasad scale. Now, distribution of patient in the various groups which we had taken. On first route in the postpartum group, there were 44 patients. And as we can see, the continuation rate, that is up to the 4 dose. The maximum continuation rate was in the postpartum group, that is 36.3%. And as earlier, we had also seen that the acceptability was also maximum in the postpartum group. So the acceptability as well as the continuation rate, both were maximum in the postpartum period, followed by the interval period where the continuation up to the 4 dose was 23.3%. And in the post-aborted, it was only 20% up to the 4th dose. Now, reasons for discontinuation, which we had observed, the majority of the reason for discontinuation were the menstrual changes, and followed by some other things which we had observed that after some time, patient tried to switch to other method like some sterilization. Some patient opted for sterilization, some for more longer period acting contraceptions like intrauterine devices. Other minor side effects which we observed were like BP changes in 1.1%, mood swings in 2.2% of the dropouts, and weight gain in 5.5%. This is among the total dropouts which we had observed. Now, coming to the effect of DIMPA on the menstrual pattern, which was the major side effect which we had observed in our study. 31.9% of the women reported amenorrhea of the total number of the usage. And we can see that the majority, after the first dose, the main side effect which we can see is 31.9%. But there is a clue in this, that this is because the postpartum period, women were already having lactational amenorrhea. Otherwise, when we will observe, it is the spotting, which is more in the rest of the other groups after first dose. This is that same graph only of the table. Now, after the third dose, we observed that the menstrual pattern changes. And now it was amenorrhea, which was predominant in all the 3 groups. And it was 43.8% of the DIMPA users after third dose had developed amenorrhea. This is the graph.
Your time is over.
Okay, ma'am, I'm just winding up. DIMPA effect on weight was analyzed, and it was found to be significant by the Friedman two-way analysis. The mean weight gain was 2.1 kg, 2.21 kg, and the p-value was 0.00, showing that it was significant. DIMPA effect on mean arterial BP was also analyzed, and it was again found that it was p-value was 0.77, and hence we realized that there was no significant difference in the mean arterial BP. No effect on lactation was noted in the postpartum group, and it was found to be 100% effective. Myths surrounding DIMPA, various myths which we had taken, they were mostly in the menstrual patterns only, and as we can grossly see that all the yes saying women were more than 50% for all the questionnaire. This says that predominant menstrual myths were prevalent regarding DIMPA. Now, the continuation rate was compared to various studies, and we can see the continuation rate in our study after third dose was 27%, which is similar to the UNPF India study, which was a multi-centered study done in India, and it was 41%, and it is more than the 13% CLIF study, which was a Tunisian study. Reason for discontinuation were compared to other studies, and majority were menstrual irregularity in all the studies. Now, coming to the conclusion, despite proper counseling, less number of patients, that is only 47% of the total counsel, opted DIMPA as contraceptive. Acceptance was more in the postpartum period, and hence we should focus on this group, as acceptance can be further increased in this group by emphasizing on the postpartum visit and by making proper counseling. Menstrual changes were the major side effect which were observed, and it was responsible for dropout in 39.7%. Other minor side effects were weight gain and mood changes, which contributed only to the minor percentage of dropout. Proper counseling and hence can minimize the dropout rate during the follow-up visit. Thank you, ma'am.
Since Neha, you have shoot up your time, we will not give you time for discussion. You already taken 9 minutes. It was 6 plus 2. Okay. So we will switch over to our next speaker. Before that, I want to welcome Dr. Madhu Singhal. She is the next co-coordinator for the next sessions. Welcome, ma'am. We have already done till number 10, Dr. Madhu. So next, I think Vajanti is there.
Yes, ma'am.
Vajanti, you can start with your slides.
Yes, ma'am.
Ms. Vajanti, I may request you to switch off one of the systems. Ms. Yapi, may I request you to stop sharing your screen right now?
शेयर किया है, ये आ रहा है. Unable to share, नहीं पा रही हूँ.
Yapi, may I request you, because Miss Vajanti is sharing her screen.
Yes, ma'am, I'm sharing, but unable to share the slides,
Yeah,
ma'am.
because Miss Yapi shared her screen right now. We have just informed her.
Yapi, you'll have to stop sharing, please. Vajanti will do now.
Yeah, Miss Vajanti, you can try now.
Yes, ma'am, I'm presenting. Good afternoon to all
Once again,
respected faculty
sorry,
members.
Miss Vajanti, we are just able to see your eyes. May I request you to flip the screen a bit down?
Yes,
Yeah,
ma'am.
yeah. Please do this checks whenever everyone is joining. It will help us to save our time.
Please share your slides fast, Vajanti.
Yes, ma'am, I'm sharing. It's not able. Yes, ma'am. Okay. Good afternoon, ma'am. My topic is misoprostol only versus mifepristone plus misoprostol in induction of labor following intrauterine fetal death. It was an open-label randomized control trial. My guide is Professor Renu Singh, ma'am, and from Department of Obstetrics and Gynecology, King George Medical College. Introduction. IUFD is defined as the death of a fetus at or after 20 weeks of gestation. It's encountered in 1% of all the pregnancies. Over 90% of the women deliver spontaneously within 3 weeks of within 3 weeks of the event. Induction of labor to reduce maternal anxiety and complication. We aim to conduct an open-label randomized control trial to compare the efficacy of mifepristone plus misoprostol versus misoprostol alone for induction of labor in women with intrauterine fetal death. Aims and objective were to find out the induction delivery interval with the misoprostol alone in IUFT and to find out the induction delivery interval with the use of mifepristone and misoprostol in IUFT and to compare the effectiveness of both the regimes. Material method, study design was open label randomized control trial. Study type was interventional type and the proposed sample size was 100 and the total number of the women enrolled in this study were 180. The study was done after the approval from the Institutional Ethical Committee. Subject selection criteria, inclusion criteria, intrauterine fetal deaths with the period of gestation more than 28 weeks and women with the singleton fetus were considered and women who were not in labor and willingness to participate in the study were included. Exclusion criteria had the women with the transmural uterine incision who had cesarean section or history of myomectomy, multiple pregnancy, grand multiparity, parity that is more than 4, malpresentations, placenta previa, contracted pelvis, and the patients with the known allergy to use of mifepristone and misoprostol were excluded. Now, the study protocol was patients were enrolled, detailed clinical history and examination was done, routine investigations were sent, and the consent was taken. And group 1 had the patients in whom both the mifepristone was followed by misoprostol, and group 2 had the patients in whom only misoprostol was given. Now, this was the protocol which was done. 180 patients were enrolled, were taken for the eligibility, out of which 150 were included and enrolled. Out of this, 40 patients did not meet the inclusion criteria because of the parity more than 4 and 15. Previous cesarean section had in 10 patients, placenta previa with the 5 and the malpresentation with the 7. Patients were randomized with 110 in 55 in each group. 55 now, in group 1, 53 patients received the intervention, while 2 did not receive. While it was in group 2, only 52 received the intervention, while 3 had not received. In group 1, 3 patients had discontinued the intervention, while in group 2, there was 1 patient who lost to follow-up and 1 patient discontinued the intervention. In analysis, only 50 patients were included in both the groups. In dosage, group 1 was given 200 milligram tab mifepristone was given orally, followed 24 hours later by the tablet misoprostol 50 microgram, which was kept vaginally 6 hourly, maximum for the 5 doses. In group 2, tab misoprostol 50 microgram was given vaginally 6 hourly, maximum for the 5 doses. Primary outcome was calculated as successful delivery and induction to delivery interval was seen. In secondary outcome, doses of misoprostol required, side effects of the misoprostol seen, and need for the augmentation with the oxytocin was noted. Primary outcome. in primary outcome, I've seen that 84% of the patients in the group 1 delivered successfully, that is within the 24 hours of prescription, 24 hours of giving the misoprostol, while in the group 2, only 66% of the patients delivered after misoprostol within the 24 hours. Now, this is the induction delivery interval table, which shows that in group 1, maximum patients, 27, within 12 hours of the 12 hours of the administration of the misoprostol delivered, and while in group 2, 20 patients were delivered in the 12 to 24 hours of administration of misoprostol. That the mean was 13.7 plus minus 10.3 hours in the group 1, and it was 18.8 hours plus minus 9.9 in the group 2. Conclusion of this study was that the age of enrolled women ranged from 19 to 40 years. In the majority were the primary gravidas. Both the groups were comparable with respect to the mean pre-induction Bishop score. Successful delivery was significantly higher in the group 1 as compared to the group 2. It was 84%, as I explained before, in versus 66%. The mean induction delivery interval in group 1 was 13.7 plus minus 10.3 hours, and in group 2 it was 18.8 plus minus 9.9 hours. Group 1 had significantly less induction delivery interval than the group 2 women. And 22% had the hypertensive disease related disorders, hypertensive disorders in pregnancy as important cause of the intrauterine fetal death. And fever, headache, and nausea were the common side effects which I noted. Thank you, ma'am.
Okay. So the judges, any questions for that?
What was the incidence? What was the reason for cesarean section, and the incidence of fetal distress in your study, fetal outcome?
Ma'am, I have taken the patients which came to our OPD with the intrauterine fetal deaths.
Okay, I missed it out. So some of the patients who were induced went for cesarean also. So they were for CPD or any medical reason, like you said, it was preeclampsia.
Yeah, ma'am, but in my study, I've seen that every patient delivered, ma'am. There was no, because the oxytocin was also given.
So the delivery rate was 10%.
Yes, ma'am, but successful delivery was not, successful delivery was 88% in the group 1 and 66%, 80% in the group 1 and 66% in the group 2.
What do you mean by successful delivery?
Ma'am, successful delivery means ki after the administration of the tablet misoprostol within 24 hours, after the 24 hours of administration of the misoprostol, patient is delivered or not. And in this 6 hourly, the misoprostol was given, and maximum the 5 doses has to be given.
So was there any unfavorable outcome when the delivery was duration was prolonged after 24 hours?
Yes, ma'am. Patient.
Some patients do you call it unsuccessful? Do you call it unsuccessful?
No, ma'am.
Do you call any delivery which is?
Ma'am, some patients had
if the
complained
induction
of
delivery interval is more than 24 hours, you call it unsuccessful.
Yes,
Will it
ma'am.
be
We can
unsuccessful?
call, ma'am. We can call that, but ma'am, 84% have delivered. So, ma'am, it was seen that ma'am, 84% patients had delivered within the 24 hours of an. Ma'am, 84% patients have delivered within
interval between
in group 1.
mifepristone and misoprostol.
Ji, ma'am.
Interval between mifepristone and misoprostol.
Ma'am, 24 hours. Ma'am, 24 hours.
So you counted the time from misoprostol.
Yes, ma'am. Ma'am, because mifepristone gives.
Okay.
0.038 है तो p वैल्यू उसके सिग्निफिकेंट है चेंज की कोई सिग्निफिकेंस ही नहीं है वो शो ही नहीं
Vajanti, you have also taken into account the duration of hospital stay and what was the period of gestation. You have not taken that into account. You are not audible, Vajanti. You are not audible.
Vajanti, you're on
Unmute yourself.
Yes, ma'am. Yes, ma'am. Ma'am, am I audible?
Yeah.
Yes, ma'am.
You have not even included the period of a table in which the indication for induction should have been mentioned. Besides IUFD, what were the other factors? Like gestational age?
I have included, ma'am, patients, ma'am, I have the exclusion criteria of the patients having transmural incision.
No,
incision, ma'am, and the
like
yes,
you
ma'am.
are saying that 20% of the patients were having PIH. The most common indication was
22%, yes, ma'am.
preeclampsia, huh? And what
Ma'am.
was the gestational age?
Ma'am, more than 28 weeks of period of gestation was taken.
All the patients after 28 weeks. Nobody is before that.
Ma'am, it was my inclusion criteria to take the to admit the patients with the period of gestation more than 28 weeks in my study.
And even previous one or previous two section were included except the.
No, ma'am.
No,
ma'am,
you
they
have
were not.
mentioned.
Ma'am, I have mentioned it, ma'am. In exclusion criteria, that patients with slide.
No, it's okay. But
yeah,
ma'am, I have not taken the patients with the uterine scar. Matlab, if patient had any uterine surgery like myomectomy or previous one LSAs, I have not taken that.
And what were the major complications? Any major complications between the two groups?
Ma'am, actually fever, nausea, vomiting was seen in the patients receiving misoprostol only, in the group who received only misoprostol, because there were the only 66 patients who have delivered.
Both the groups have received misoprostol, beta?
Yes, ma'am, both the patients have received, but ma'am, patients in the group 1 had delivered with the less doses of misoprostol, but in group 2 more doses of misoprostol was given. Some patients have given 6 or 7 doses too. So, ma'am,
and what was the duration of stay of the two groups? Hospital stay?
Ma'am, it was, I have not calculated that, ma'am, but it's around, ma'am, 3 to 4 days, ma'am. Ma'am, because
that is too much.
Okay.
Okay. Chalo. Who's the next? Nisha is there. Nisha Gautam.
Ma'am, actually, Ruchi Pandey is also pending, but
who?
Ruchi Pandey.
Ma'am, Ruchi Pandey has done.
Okay.
Ruchi Pandey has completed.
Okay.
Now the next is Richa Gautam.
There is two
and
girls.
I would request the participants, please
Fatima
stick
are
to
not
the
there.
time.
So Dakshi and Fatima are not there?
No, they didn't. I couldn't see them in the list.
No, yeah, they couldn't.
Miss Yapi, I would request you to switch off your video. We would let you know if your when you are turned up. Let's go with the chronological order right now.
Yeah, we will take her later on now. We will take Share screen पे जाके a lot of time.
Miss Nisha,
yeah, we can.
Nisha, there's a lot of back disturbance from your end, and may I request you to also switch off your video?
Good morning, ma'am. Am I audible?
Yeah, you're audible. Your voice is echoing. Are you using two sources?
No, ma'am.
Chalo, okay, start.
Good morning, ma'am. My topic is T-cell metabolomics in preeclampsia and pregnancy with chronic hypertension. Under the chief supervisor, Professor Amita Pandey, in Department Ops and Gynae, KGM Lucknow. Introduction: preeclampsia is a complex medical disorder. Preeclampsia is a complex medical disorder, affects 5 to 7% of pregnant women each year worldwide. Preeclampsia is still being managed by strict monitoring, symptomatic treatment, and termination of pregnancy being the standard management of preeclampsia. Some theories stated that increased TH response cause chronic inflammation and imbalance of TH1 ratio, which may lead to development of preeclampsia.
6 minutes
Depression of correlation of inflammatory cytokine with the development of hypertensive disorder pregnancy.
आपके पास लिस्ट है ही है ना, तो आपने अब जी जी, तो आप चाहे तो बीच में अनाउंस कर दीजिएगा, नेक्स्ट को बुलवा लेंगे हम, ठीक है।
May provide us some insight into pathogenesis of preeclampsia. These cytokines may further be used as biomarkers for predicting the development of preeclampsia.
इंट्रोड्यूस कर देंगे, स्लाइड शेयर मैं कर दूंगी, मेरी ऑलरेडी ओपन
As it is complicated and expensive to study T regulatory cells directly, so we studied the metabolites of T regulatory cells as interferon gamma, interleukin 1, TNF alpha, interleukin 6, interleukin 4, interleukin 17, interleukin 23, and T regulatory cells cytokine interleukin 10. My aims and objective were to measure and compare the level of T cell metabolites in preeclampsia, pregnancy with chronic hypertension, and normal pregnancy, to correlate the level of T cell metabolites with severity of disorders and fetal-maternal pregnancy outcome in 3 groups. Material methods. My study site was in Department of Obstetric and Gynecology, KGMU, Lucknow, after taking ethical approval from KGMU. My study was prospective analytical study and done over 150 women divided in 3 groups, 50 in each. Group A comprises of pregnancy with preeclampsia with period of gestation beyond 28 week to term. Group B comprises of 50 women having pregnancy with chronic hypertension, and Group C comprises of normal normal pregnancy with period of gestation beyond 20 weeks till term without any complication. All women admitted or attending with diagnosis of preeclampsia, pregnancy with chronic hypertension, and healthy pregnancy were included in the study after ruling out exclusion criteria, which was any comorbidity like liver or pre-existing liver or kidney diseases and autoimmune diseases. Proper consent was taken before study. Sample of venous blood were taken and transported to immunology laboratory SGPGI Lucknow, maintaining cold chain. The venous blood sample underwent ELISA testing to measure the level of T cell metabolites. All women who registered in the study were followed till delivery for fetal-maternal outcome. T cell metabolite level and their fetal-maternal outcome were compared among the 3 groups. Results. My 150 patients were divided into 3 groups, 50 in each. Group A comprises of preeclamptic female, which was 33.3% of total population, and Group B comprises of chronic hypertensive pregnant female, which also contribute 33.3% to overall population, and Group C was a normal pregnant female, which also contribute 33.3% to normal to whole population. In our study, it seems that I observed that level of pro-inflammatory cytokine, level of all the pro-inflammatory cytokines were significantly raised in Group A. Group A comprises of pregnancy with preeclampsia, in comparison to Group B and Group C, while T regulatory cells were decreased in pregnancy with preeclampsia and was normal in pregnancy with normal pregnancy. The level of all the pro-inflammatory cytokines except interleukin 10 was raised in women who stayed for 7 or more than 7 days in comparison to women who stayed for less than 7 days, while regulatory cytokines were significantly decreased in women who stayed 7 or more than 7 days in hospital. It also seems that level of pro-inflammatory cytokines except interferon gamma, and interferon gamma was found significantly raised in women who required ICU care. And the level of pro-inflammatory cytokine interleukin 23 was found significantly raised in women who developed postpartum eclampsia. Level of inflammatory cytokine like interferon gamma, interleukin 6, interleukin 17, and 23 was also found significantly raised in women who experienced maternal near miss condition. And while the level of anti-inflammatory regulatory cytokine interleukin 10 was significantly decreased in these women. We also
Nisha, please try to wind up. Your time is almost up.
Okay, ma'am. The level of pro-inflammatory cytokines also found raised in women whose baby required NICU care and fetal complications. Uh, Rate of cesarean was significantly higher in group B. Group B means pregnancy with chronic hypertension as compared to group A and C. We found that the level of cytokine except interleukin 10 was significantly higher in group A as compared to group B and C. The level of interleukin 10 was significantly higher in group C, which was normal pregnancy, followed by B and A. We found that the mean level of pro-inflammatory cytokine like interferon gamma, TNF alpha, interleukin 1, interleukin 6, 17, and 23 was significantly raised in group A, means pregnant women with preeclampsia. And mean level of regulatory cytokine interleukin 10 was found lowest in group A, means pregnancy with preeclampsia. The value of interleukin 10 and 17 was maximum for group C, followed by group A, which indicate a positive anti-inflammatory response in normal pregnancy with normotensive women. Conclusion: the level of cytokines secreted by different subset of T cell in study population. Pro-inflammatory cytokines were significantly raised in women with preeclampsia and chronic hypertension and normal pregnancy, while protective and anti-inflammatory cytokine like interleukin 10 was significantly raised in women with normal pregnancy as compared to women with preeclampsia. Babies born to mother with raised pro-inflammatory cytokines had lower birth weight, required more NICU care, and experienced more complications, while higher level of pro-inflammatory cytokine associated with increased need of postpartum ICU care, increased rate of renal injury, postpartum sepsis, maternal near miss conditions, also more postpartum complication and worse pregnancy outcome like IUD superimposed severe P and postpartum eclampsia than their normal counterparts. Ma'am, you are not audible.
You have already taken 6 plus 2 minutes, Nisha, so we will not allow the discussion part in your presentation. We will now move to the next presenter. Who is the next presenter?
Ma'am, Parul Sharma.
Parul Sharma. Is Parul there with us?
Yes, ma'am.
Please try to stick to your time, otherwise you will be losing marks on the discussion part. I am telling again and again, please stick to the time. So, Parul, you can share your slide.
Yes, ma'am. Good morning, everyone. I'm Dr. Parul Sharma, junior resident at KGMU Lucknow. My topic is a randomized controlled trial to compare provider and client acceptability of thermocoagulation and cryotherapy in VIA positive cervical lesions. My chief supervisor is Professor Uma Singh, ma'am. As we all know, cervical cancer is the fourth most common cancer among women worldwide, and it has a long precancerous phase which provides ample opportunity for detection and successful treatment. Various treatment modalities are available for cervical precancerous lesions, include ablative and excisional procedures. Ablative procedures including thermocoagulation and cryotherapy, and among them, thermocoagulation is more re-emergent technique, which has various advantages over cryotherapy, including ease of use, portability, shorter treatment time, and it has lesser side effects. Recently, WHO has also endorsed thermocoagulation as a safe and effective ablation technique, but this recommendation is still conditional and based on very low certainty of effects. WHO seeks for more evidence, especially studies which require health delivery models of screen and treat strategies, and studies on comparing thermocoagulation against the prevailing standard modality, which is cryotherapy. And therefore, we conducted our study to assess the acceptability of thermocoagulation in VIA positive lesions and to compare it with that of cryotherapy. The study was conducted, it was a randomized controlled trial conducted in our department over a period of 1 year, and the sample size was 92. Total 880 women were screened, 30 to 50-year-old, 880 women were screened over a period of 1 year, out of which 104 women were VIA positive, making the VIA positivity rate of our study as 11.8%. Total 12 women were excluded from our study on the basis of exclusion criteria, and some declined to undergo the procedures and some declined to come for follow-up.
92 VIA positive women were then randomized by using computer-generated random numbers and divided into two groups, Group A and Group B. After proper consent, the women in Group A received cryotherapy, and those in Group B were treated with thermocoagulation. After the procedure, the provider and client acceptability of the procedure was assessed by using an IARC-validated questionnaire, and also the immediate side effects were assessed after the assessed and noted after the procedure. Thereafter, the women were followed up at 6 weeks and 6 months for any side effects and their acceptability, the client acceptability. Now, I would like to discuss my results. While assessing the provider, the degree of provider acceptability, the degree of satisfaction of provider was assessed under various parameters, including the ease of use, the satisfaction with the probe length and shape, and ease of setting up of instrument, and also acceptability by the patient as perceived by the provider. And as we all can see that the providers found thermocoagulation was very easy to use. They were very satisfied with the probe length and shape of thermocoagulator, and thermocoagulator was more easier to set up compared to cryotherapy, as it does not require heavy gas cylinders, or it runs by electricity. And the acceptability of the patient was similar in more in thermocoagulation, but it was not statistically significant. While assessing the technical problems faced while using the instrument, the providers did not find any technical difficulty while using the thermocoagulation. On the other hand, while doing cryotherapy, there were few incidents where the procedure had to be stopped or rescheduled due to unavailability of gas cylinders, or gas cylinders were empty, or 2 times there were gas leak issues also. So the procedure had to be rescheduled. And regarding the satisfaction of sterilization procedure, providers are more satisfied with the thermocoagulation, because we use the sterilization procedure as 120 degrees Celsius for 60 seconds. But for cryotherapy, we wipe the cryoprobe with the spirit. When the provider was asked to assess the advantage, to state the advantages of thermocoagulation over cryotherapy, various advantages were mentioned, including its shorter treatment time, it has lesser side effects, the low maintenance, and it's easier to perform, and the more easy portability, and it has easier way of sterilization. Although some providers, 13% providers, felt that it required electricity supply could be a disadvantage of thermocoagulation. But now we have newly introduced battery-driven unit of thermocoagulation, which is laser thermocoagulator. So that can be tackled up with the battery-driven unit. While assessing the client acceptability, the immediate side effects were assessed, and significantly more patients who were treated with thermocoagulation had no complaints immediately after the procedures. And while in cryotherapy, significantly more patients had mild abdominal pain after the procedure, which did not require any medications. At 6 weeks follow-up also, significantly more patients were asymptomatic at 6 weeks. And the most common complaint among the patients was vaginal discharge, which was significantly more in cryotherapy group. These were some of the pictures from the procedures done and after thermocoagulation, and this is after cryotherapy, and also at 6 months follow-up. And I'll conclude that VIE is a simple and uncomplicated and painless procedure, which does not require high-end setup, especially in low resource setting. So it is a very useful screening tool. And after objective quantification of acceptability using the IARC validated questionnaire, compared to cryotherapy, thermocoagulation offers better provider acceptability and better client acceptability in terms of its ease of use, its portability. It requires lesser technical demands, and also it requires a lesser treatment duration and lesser side effects. Thank you, ma'am.
Yeah, so Parul has completed well in time. We can have time for some questions.
Parul, what is the mechanism of cryotherapy? What is the difference between the mechanism of cryotherapy versus the thermocoagulation?
Yes, ma'am. Cryotherapy works by tissue. It causes, it causes tissue necrosis. The cryotherapy, and in thermocoagulation, there is the coagulation of proteins.
Okay. And any major side effect of the thermocoagulation which you might have encountered during your study?
Ma'am, the most common side effect was vaginal discharge, watery vaginal discharge, which was resolved in within 6 weeks, but it was more in cryotherapy. This side effects was similar in both the groups, in cryotherapy group and also in thermocoagulation group. But the thermocoagulation patients became asymptomatic earlier than cryotherapy group.
Okay.
Is that all for the questions? Then we can call the next speaker. Dr. Madhu Singhal, ma'am, you can call the next speaker. Do we have Shefali? After that, we'll come to Yapi, okay? And then we will, the judges will change. Shefali is there?
Yes, ma'am.
Shefali, please share your slides immediately. We are running short of time.
Parul, you may switch off your video now.
Yes, ma'am.
Good morning, respected teachers. The topic of my paper is the correlation of menstrual abnormalities.
We cannot see your slide. Yeah, now it's visible.
Good morning, respected teachers. The topic of my paper is correlation of menstrual abnormalities according to FIGO 2011 classification with endometrial histopathology in the Department of Obs and Gynae, KGMU, Lucknow, under the guidance of Professor Nisha Singh ma'am. Approximately 1/3 of women are affected with AUB at some point of time in their life, with a prevalence of 3 to 30% women in reproductive phase. Furthermore, 25% of gynecological surgeries are done for AUB, which leads to 2/3 of all hysterectomies. In 2011, considering the global impact of menstrual abnormalities, FIGO published a pair of systems and clinical recommendations, the aim of aiding clinicians and investigators in the formulation and interpretation of investigations into AUB. It was thereby recommended that unclear terminologies be abandoned. Instead, clear and simple terms that the general community could understand were introduced. Despite the FIGO 2011 publication, the review of world literature showed that only few studies have reported the use of terminology of AUB. Aims and objectives were to classify the cases of non-structural menstrual abnormalities according to FIGO 2011 symptom classification, to study endometrial histopathology in above cases, and to find the correlation between menstrual symptoms and endometrial histopathology in the above cases. My study was prospective analytical study. Duration was 1 year in the Department of Obs and Gynae, KGMU. Total of 225 women with non-structural AUB from the OPD were enrolled. Inclusion criteria were women of reproductive years, perimenopausal and postmenopausal group presenting with AUB of more than or equal to 3 months were enrolled. Exclusion criteria was pregnancy, unmarried and adolescent females, the patients with endometrial thickness of less than 4 mm, uterine size above 6 weeks, the clinical and sonological diagnosis of fibroid or polyp, any hormone therapy in the last 3 months, and not willing to undergo endometrial biopsy. Methodology was the patient, all the patients of endometrial all the patients of AUB underwent history and gynecological examination. TVS was done to look for uterus, adnexa, and endometrial thickness. All patients underwent endometrial aspiration via Karman's cannula number 5 and disposable syringe 20 cc, and the tissue was sent for HP. The cases were classified according to FIGO 2011 symptom nomenclature, and then they were correlated with HP findings in the phase of life. This was the classification that we used. They were broadly classified according to the frequency of the menses, the regularity of the menses, the duration, and the volume of the menses. The newer terminology was used. Results: the most common age group of non-structural AUB was 31 to 50 years with a mean age of 39.73 years. Menstrual symptoms were most common in the reproductive phase. Menstrual irregularities was most common in the Paris women. 73% women were Paris. The most common, this is the distribution of cases according to the symptom. The most common symptom with the patients presented was heavy menstrual bleeding, 66 postmenopausal, and they're followed by the postmenopausal bleeding. This is the incidence of different menstrual symptoms in different phase of life. We can see the scanty menstrual bleeding was most common in the reproductive phase of life, which was statistically significant. Heavy menstrual bleeding was also common in the reproductive phase of life, while the prolonged menstrual bleeding is common in perimenopausal group. Infrequent and irregular menstrual bleeding was also common in the reproductive phase of life. These were the various endometrial histopathologies which were encountered. Approximately 30% had normal endometrium, while 70% had abnormal endometrium, out of which proliferative endometrium seen in the secretory phase of life was seen in the most common, followed by simple hyperplasia, endometrial adenocarcinoma. These were the symptoms we correlating which HPE findings. We found only amenorrhea, heavy menstrual bleeding, scanty menstrual bleeding, and postmenopausal bleeding was statistically significant with the endometrial histopathology. Amenorrhea was in amenorrhea. Proliferative endometrium seen in secretory phase of life was most common endometrium encountered. In scanty menstrual bleeding, secretory normal endometrium was most commonly seen. In heavy menstrual bleeding, proliferative endometrium, which is out of phase, that means proliferative endometrium seen in secretory phase of life was most common. In postmenopausal bleeding, also the proliferative endometrium was most common. This is the association of HPE findings with the phase of life. We found that secretory phase endometrium was most common in the reproductive phase of life, and which was statistically significant. We found the secretory endometrium, which was out of phase, was common in the perimenopausal age group. Endometrial adenocarcinoma was most common in the postmenopausal age group, and also the simple hyperplasia was common in the postmenopausal age group. From the study, we drew the conclusions that non-structural abnormal uterine bleeding is common in reproductive phase of life, with heavy menstrual bleeding as the most common symptom. Amenorrhea, scanty menstrual bleeding, heavy menstrual bleeding, and prolonged menstrual bleeding was significantly associated with endometrial pathology, highlighting the importance of endometrial sampling. The limitations of a study was, though endometrial biopsy is a simple procedure, it is not acceptable by significant number of patients, and this insisted on medical management. In our study, 75 patients refused for the endometrial biopsy, and the strength of our study, the present study has been able to classify AUB as per cases of newer nomenclature and correlate the symptoms with endometrial histopathology. Thank you.
What was your sample size, Shefali?
225 women were enrolled.
Okay. And you have divided them into the 3 categories.
Yes, ma'am. We have divided phase of life. We have divided into 3: perimenopausal, reproductive, and the postmenopausal.
Okay. So, any correlation you have seen with the TVS or ultrasound, your histopathology with in the perimenopausal age group?
Yes, ma'am. When we found the endometrium, we found that most common the endometrium which were encountered was 6 to 26 that we took, 6 to 626 mm, and the mean was 10 mm that we did endometrial biopsy. The mean thickness was 10 mm. Ma'am.
And you have done the endometrial biopsy of all the patients, even in reproductive age group?
Yes, ma'am. Or in all the age groups.
They were all ready for endometrial biopsy?
Yes, ma'am, they were ready. Ma'am, 75 patients, ma'am, refused, but 225 patients, ma'am, were ready for the biopsy.
Okay. Any other questions?
Dr. Shefali?
Yes, ma'am.
Dr. Shefali?
Yes, ma'am.
Yes, I have one question. You correlated with the in postmenopausal patient also get most of the time is the proliferative type of endometrium.
Yes, ma'am. We got proliferative endometrium, which was out.
Present. Okay. This is a histopathological. You are not correlated with the hysteroscopy or ultrasound finding and that patient of postmenopausal woman.
No, ma'am. We have not. We have just correlated with the endometrial findings. We have not correlated with the hysteroscopy, ma'am.
So those are getting the proliferative. Most of the patient presented with the HMB.
Yes, ma'am. Those patients presented with postmenopausal bleeding, and ma'am, HPE findings for proliferative endometrium, ma'am, which was out of which was abnormal proliferative endometrium, which was not normal.
Could we say what will be cause of that proliferative in the postmenopausal women if you are not excluding the other factors?
Ma'am, could be the pre-malignant lesions, ma'am.
It is. मतलब co-factor could be a BMI. पेशेंट का जिनमें proliferative मिला उनका BMI क्या था उससे correlate नहीं किया तुमने?
No,
Why
ma'am, we have
the
not.
proliferative in the postmenopausal? Some pathology should be there, no? Estrone is there. stone is there basically. Hyperestrogenic condition is there. So BMI is one of the factor, and other metabolic syndrome could be a bias factor. You should rule out that. I think so.
Yes.
Okay.
Were there any cases of scanty or nil curatings?
Ma'am, no, we excluded those, ma'am. There were some, ma'am, but we excluded that from our study, ma'am. We do not, ma'am, include in our analysis, ma'am.
So this is another limitation of your
Yes.
study.
Yeah.
ठीक है. So Yapi, you can try giving one try more for your slide share. Okay.
Miss Yapi, you may have to click on share
Can I
screen
start?
and select the PowerPoint presentation over there.
No, but your slides are not visible, Yapi.
I'm sharing.
You're still not able to see your slides, Yapi. Who's the next speaker?
Rupa.
तारीख तो समाप्त हो गया, ये नहीं लिखना है.
I think we'll have to. Yapi, are you listening? Unmute yourself.
Yapi.
We cannot give that much time to a candidate. So long.
She has not sent her slides to Srishti.
Chalo, let's see if it works now. Start your presentation, Yapi. Unmute yourself.
Miss Yapi, I have sent a request for you to unmute yourself.
Chalo, start quick. Yapi, what's the problem? Please start fast. Probably she's again having the network problem.
It's a network problem. If you are connected with the hotspot or something like that, then there might be some intervention. I'm sharing a link in the chat box for everyone to see the uploading speed, which is more than 5 to 10 Mbps.
Hello, is it visible? Hello.
Miss Yapi, you're not loud. It may be loud.
Ma'am, is it visible?
It is visible, but we are not. You are not audible, Yapi. You are not audible.
Yes, ma'am. Am I audible now, ma'am?
It's very slow. Speak out. Let's see if we can hear you, because this is the last try we are giving you. We cannot wait for so long for one candidate. Start now.
Yes, ma'am. Ma'am, nutrition during pregnancy is an important factor associated with both maternal and nutritional infant health outcome, and it is an important level of human fetal growth. The significance of maternal nutrition is optimized outcome, and it is an amenable to change, unlike other non-modifiable factors. Maternal nutrition results in a low birth weight, which in fact leads to low birth infant mortality and morbidity. Ma'am, am I audible? Hello. Pregnancy is a period of dynamic changes. Fetus is nourished directly by the mother through the placenta. A growing fetus needs more nutrition to meet the requirement A proper dietary balance is necessary to ensure sufficient energy intake for the growth of fetus without compromising the mother's own. And in some studies, like SOVA, Ramita, in prospective study, intake of micronutrient as an important factor is that in fetal growth in undernourished community, and like similar.
हो गई है। इसको मैं बोलूंगी, ये सुने तो कि रिव्यू ऑफ लिटरेचर नहीं बोलेगी। अनम्यूट योरसेल्फ यापी। And don't speak out the review of literature. You don't have to speak out about review of literature so long. Skip it and come to the next slide. Don't speak about the review of literature again. Skip.
Okay, ma'am. Here we have with age objective assessment of dietary intake and nutritional status of urban ANC women of Kanpur visiting our hospital to plot a dietary deficiency or excess chart according to the assessment. And my study is a prospective observational study in Department of Obstetric, GSBM Kanpur, and where we had 36 patients from the time period of February.
बीच बीच में म्यूट हो जाती है ये स्लाइड गायब हो गई।
Miss Yappy, if you click on escape or something like that, your share screen will go away. So make sure that you click on the right buttons when you are sharing the screen.
Yes, ma'am. Already, my colleague has already presented. So, and inclusion criteria were age between 20 to 35 years, pregnant women in early pregnancy ready to be included in the study, attending antenatal clinics from the start of their pregnancy till the end of the second trimester, and
Yappy, we cannot see your slides.
Less than 20 years and more.
Yeah, now it is visible. Okay.
Ma'am, it is already shared from my side. Yes, ma'am. Ma'am, exclusion criteria were pregnant women less than 20 years and 45 years, and high-risk pregnancy were excluded. 8 to 9 months of gestation age were excluded. Addiction to any kind of abusive substances. And data collection tools were 24-hour dietary recall question methods. Estimation of nutrient intake and anthropometric measurements were used. Height, weight, BMI, mid upper arm circumference were used. Hemoglobin level was also.
Again, it is lost.
तो हो गया होगा इसका 6 आप ही का लगाया था टाइमर।
There was some technical error.
I think we will have, Yapi, your time is almost running short. We are not able to listen to you. So we would not allow you to continue more because we are running short of time. Okay?
Yes, ma'am. Observation and distribution of age were mostly 20 to 25 years old. And most of the height between 1.5 to 1.65 meters, and weight were mostly less than 50 kg.
मुझे 6 मिनट्स हो जाए तो बता देना।
Miss Yappy, please click double tap on enter.
Ma'am, I think her time is
Yeah, for almost 6 minutes, Yapi, we would not be able to let you continue more. Okay, we cannot allow this much time for one candidate. So you can stop sharing your slides now. And we have completed with the 14 candidates. The 2 who have not logged in will not be allowed to participate now anymore. If they come, we'll see in the last. So I thank my judges for this session, Dr. Vani and Dr. Babita. Thank you so much for your kind presence. You can continue being with us. We'll be very happy.
Thank you, Dr.
Nilima.
And we shall be, how should we send you the results?
You can send me on WhatsApp. You can compile and take a screenshot and send me, ma'am, both of you.
Okay, thank you so much.
Thank you so much. Thank you, Dr. Vani and Dr. Babita. Thank you so much. Srishti, I will like to share the slide.
Ma'am, number 26 is Ma'am, number 26 is still left.
20?
Ms. Prati, there is 14 numbers.
No, we have completed till 14 number now. We'll be starting with 15 number. Okay, don't worry. From 15 till 28, we are still left. Don't worry, the students. This is still 14 only. Okay, we are having the change of judges from now. So that is why I was saying. Srishti, I have to share this slide. Can I?
Yes, ma'am, you can.
Dr. Madhu Singhal is there, ma'am? Dr. Madhu Singhal is there? Ma'am, please unmute yourself.
Dr. Poonamani, I welcome you on behalf of our UPCOG done by Ghaziabad team. Dr. Poonamani, she is at present working as a professor and head of the department in Rashiri Medical College, Bareilly. The next, Dr. Rehana Zanam.
Nazm.
Dr. Rehana Nazm, at present she is working as professor in the Department of Ops and Gynae in Tirthankar Mahavir Medical College, Muradabad. Yeah. So welcome to both of you as judges.
Welcome, Dr. Poonam and Dr. Rehana. Call the next
candidate.
When Dr. Madhu, we can call the next participant now.
Rupa Kumari, are you ready?
Yes, ma'am.
Then you start sharing your, start sharing.
Rupa, please share your slide.
Yes, ma'am.
Quick. And everybody, please stick to your time. We are very strict, 6 minutes plus 2 minutes. You will be losing on your marks if you do not stick to the time, because the discussion will be left with you. So please strictly follow the time.
Am I audible, ma'am?
Yeah, you are very much audible.
Good morning, ma'am. Myself, Dr. Rupa Kumari from Ops Gynae Department, KGMC. And my topic of thesis is ultrasound as a tool for predicting mode of induction in primary gravida in 3rd trimester. My chief supervisor is Professor P.L. Sankhwar ma'am, and my co-guides are Professor Uma Singh ma'am and Professor Rekha Sachan ma'am and Dr. Manjulata ma'am. Induction of labor is associated with higher incidence of operative vaginal delivery and intrapartum cesarean section. And we know that complications associated with operative vaginal delivery and intrapartum LSCS are more after induction of labor compared to spontaneous labor. And both obstetric and perinatal risks are increased after induction of labor. The aim of this study is to predict the outcome of induction in terms of mode of delivery and decrease the incidence of complication associated with operative vaginal and intrapartum cesarean sections. Objective is to predict the outcome of induction in term of mode of delivery by using ultrasound in 3rd trimester primary gravida after induction of labor. And my study was prospective observational cross-sectional study done in the Department of Obs and Gynae KGMC during the period of 1 year from May 2019 to April 2020. And women with singleton term pregnancy with cephalic presentation fit for induction of labor and patient willing for enrollment in the study were included in the study. audible now?
Yeah, you are.
And the inclusion criteria were primary gravida with more than 37 weeks of gestation, planned for induction of labor with adequate clinical pelvimetry, cephalic presentation, and patient willing for the enrollment in the study. Multiparous pregnancy and women presented in active stage were excluded from the study, and other exclusion criteria include contraindication for inductions of labor like placenta previa, fetal malpresentations, and previous cesarean deliveries, myomectomy, etc. Uncontrolled hypertension and heart disease with NYHA grade 3 and 4. We enrolled the patient after assessing the eligibility, and total 248 patients were assessed for eligibility. After that, we had done the vaginal examination followed by trans abdominal scan, trans vaginal scan, and transperineal scan was done, and induction of labor was done. Outcome was assessed in terms of mode of delivery, and those patients who delivered vaginally these are 113 patients who delivered vaginally and classified as group 1, and in group 2 we have kept the patient who delivered by assisted vaginal delivery, and the group 3 consists of patients operated for non-progress of labor, arrest of labor, MSL in latent phase, and those patients who had failed induction and operated before the initiation of uterine contraction for AFD, those patients were excluded from the study. Now, in our study, we have the percentage of cases who were induced. The maximum were for intrahepatic cholestasis of pregnancy, followed by post-diabetism, PROM, and hypertensive disorder of pregnancies as 32%, and for GDM, 16% of patients were induced, and for decreased fetal movement, absent fetal movement, 4.6%, and for FGR, 4.1% were induced. And the group-wide distribution of enrolled cases were, in group 1, we have kept the normal vaginally delivered patient, 113, which is 58.2% of the total cases. In group 2, 9.8% cases were there who experienced assisted vaginal delivery. And group 3, we have kept LSCS patients, which is 32% of the total cases. Now, the distribution of ultrasound parameter among the study groups. In TVS, we have measured the cervical length of the patient who were induced, and we noticed that in group 3, where patient delivered by LSCS, the percentage of cervical length more than 3 centimeter were highest in comparison to group 2 and group 1 who delivered vaginally. And in a transperineal ultrasound, we have measured the perineal head of the fetus and perineal distance, and we noticed that in LSCS group, the head perineal distance of 51 to 60 mm were 4.8%, which is not found among the group 1 and group 2. In group 1 and group 2, the maximum perineal head distance found were less compared to group who delivered by LSCS. And distribution according to USG parameter, the mean cervical length among the normal delivered patient were 2.77, which is less compared to the LSCS group and assisted delivered group. In LSCS, it was found 2.97 centimeter with a standard deviation of 0.63 centimeter. And perineal head distance was also found higher among the LSCS group, which is 42.3 with a standard deviation of 5.34 mm. The mean F5 was, there is no significant difference found among the group, and this is because we generally induce patient with adequate Likers in our setup. And among the TAS, we compared the position of head of the fetus and classified into two groups, whether occipital anterior position or non-occipital anterior position. And we have seen that in group delivered by LSCS, the percentage of non-occipital anterior the position was highest compared to assisted delivered group and the normal vaginally delivered group, which is 61.29% in LSCS group and 57% in assisted vaginal delivery, and only 20% among the normal delivered group. And it has the statistically significant data among when we compare the position of the head of patient.
यार प्रियंका फटाफट करके निकल ताकि दूसरे को भेज, जल्दी जल्दी से कर यहाँ पे अभी ना।
The cutoff for the vaginal delivery in terms of cervical length was less than 2.5 centimeter, and that of perineal head distance was less than 41.4 mm.
and the incidence of occipital posterior position among group 3 was 61.29%. The conclusion of our study is combination of several ultrasound parameters can be definitely used as a predictor for outcome of the induction of labor, and the in the strength of the study, different ultrasound parameters separately as a predictor of outcome of induction of labor was used. However, in our study, we aim to determine whether a combination of several ultrasound parameters like estimated fetal body weight, AFI, fetal head position, cervical length, and fetal head perineal distance could improve the prediction of successful vaginal delivery after induction of labor. Thank you, ma'am.
Yes, judges.
Yeah. You can ask me the questions, Dr. Poonam, Dr. Rehana, if there are any.
Rupa, you want to say with your study that ultrasound will help us in monitoring the patient for normal vaginal delivery?
Yes, ma'am. We can monitor the patient after induction till the delivery, and we can predict prior to delivery whether the induction is going to be successful or whether we will land up in doing emergency cesarean sections.
But in your study, you have not incorporated Bishop score association with ultrasound, because ultrasound will help us only in making out the what is the position of the fetus. How can you assess the Bishop score and descent of the head? It is very difficult in the late pregnancy during labor. How will you do?
No, ma'am. We have included. We have done, first of all, we have done the clinical pelvimetry. Bishop score was calculated, and I have not included the slide because our study main focus of my study is to assess whether ultrasound is going to predict it or not. I have done Bishop scoring in each and every cases, ma'am.
No, like you are saying ki if we are doing ultrasound monitoring, it is better. No? That is what you are saying. But ultimate to clinical monitoring is better.
Yes, I am totally agree with Dr. Rehana.
Ma'am, we have done ultrasound only because as Bishop is a subjective method, it varies from the person to person's observation. That's why we have assessed whether ultrasound we can use or not.
But Dr. Rupa?
Yes, ma'am.
Yes, as Dr. Rehana said very rightly, the clinical is a more important than ultrasound. Ultrasound is given just is a descent and position of the fetus in a labor. And you also mentioned the AFI and all these things. How it is possible in that in simultaneously either you are doing transabdominal or transperineal? I just want to know.
Ma'am, we have done 3 ultrasound scans: transabdominal scan, transperineal, and
I know, I can understand, but I just want to you did simultaneously all these things.
First we do clinical pelvimetry, and after
because if you are not doing simultaneously, there is a time factor during the labor. So how we can justify the study?
Yes, ma'am. We have done scans simultaneously.
Oh, so how many person is required for the one patient of operating? One is a transabdominal, one for transperineal.
First, I have done transabdominal scan in which I have calculated effective fetal weight, AFI, and head position. After that, I have done transcervical for cervical length, and after that, I have done transperineal.
Okay, chalo, ठीक है.
How much cost effective this study is in Indian scenario, beta? Most of the patients are delivering in peripheries. Chalo, okay.
Can we have the next speaker?
Next, Ritu Singh. Are you ready?
Ritu?
Yes, ma'am.
Yeah, Ritu, please just share your slides.
May I audible, ma'am?
Yeah.
You're on. Please start.
Good morning, ma'am. Myself, Ritu Singh, Jayatri in King George Medical College, Lucknow. My thesis, my paper topic was study of induction of labor in women with previous cesarean section. My mentor is Professor Anju Agrawal, ma'am. Introduction: the rate of cesarean section increasing worldwide, leading to increased risks for maternal and neonatal complication in the subsequent pregnancy and labor. Previous researchers have shown that successful trial of labor after cesarean is related with minimal maternal morbidity. ACOG and RCOG has recognized induction of labor in women with previous cesarean section as the viable option. Some restriction on the use of prostaglandin in such cases. Despite of these guidelines, induction of labor for various indications continue to look for stability by many due to fear of scar descent. Aims of objective of my study was our aim was to study stability indication method and outcome of induction of labor in women with previous cesarean section. Methodology: the studies was conducted in Department of Obs and Gynae in Queen Mary Hospital, King George Medical College, Lucknow. All the pregnant women above the 28 week of gestation with previous cesarean section were screened for eligibility criteria for trial for labor. There were total 500 cases planned for induction for various indications. Out of which 230 women gave negative consent for trial of labor and 220 women gave positive consent for trial of labor were enrolled in the study. The following demographic, obstetrical variable, mode of delivery, maternal and neonatal outcome were recorded. Inclusion criteria: women with previous cesarean section admitted in Department of Obs and Gynae, willing for TOLAC, and indication of induction pregnancy, gestation age more than 28, Kim presentation, and one previous cesarean section were enrolled in the study. Exclusion criteria: women with cesarean section giving negative consent for TOLAC. Women are planned for elective cesarean section. They are not eligible for TOLAC because of having more than one previous cesarean scar, any other scar in uterus like myomectomy, non-vertex presentation, inter-delivery interval less than 18 months, inadequate pelvis, multiple pregnancy, or any contraindication related for vaginal delivery in current pregnancy. Women it already in labor are planned for spontaneous onset of labor. My result are: out of 220 studies patient, 52% are delivered vaginally, while 47.3 N is 2 to 104 had repeat cesarean section. As we told in figure number 1, correlation between age of studied group my side is out of 220, 52% had vaginal delivery, while 47% has a repeat cesarean section. Correlation between age of studies cases and mode of delivery found to be statistically significant. As with increasing age, cesarean delivery also increases. Correlation between BMI and mode and delivery found to be statistically insignificant, but with increasing BMI, chance of cesarean increases, but it is not.
इधर यहाँ सोनाली फिनिश कर ले यहाँ पे अपना प्रेजेंटेशन, तो उसको बोलना वहाँ जाएगी. कोई खास एडमिशन वगैरह तो नहीं है ना?
नहीं, एडमिशन नहीं है. एक पेशेंट है, काउंसलर है, मतलब हिस्टेक्टमी के लिए किसने काउंसल किया था.
It was seen that most common indication was repeat cesarean section was AFD, followed by failed induction and followed by non-progress.
कुछ नहीं हो साथ में. ट्रेनिक्सा लिया तो उसको फायदा हुआ था, उसके बाद फिर उसने लिया नहीं है कुछ.
Followed by failed induction, followed by arrest of descent and scar tenderness. One of the cases undergo emergency cesarean section was for acute fetal distress was found to have scar descent. As we saw in table number, chance of repeat cesarean section was significant higher in women who underwent previous cesarean section for non-progress of labor. Rate of cesarean section was found to be more in group in whom there is no history of vaginal birth. However, difference was not statistically significant. Gestational.
Ritu, we cannot hear you.
Yes.
So you need not click on anything else. Just click on the cross here on the screen. Close it.
Yes, ma'am.
Just cancel it. Just close it now. Click on the close button. It is written over here. Close, close. See, it is written close. In the same line, close is written. Click on cancel. Close. No, you do not need to click on options, Ms. Ritu. You need to click on close. See here, it is written in the same line as options.
To click on cross.
Yeah, click on the cross also. Ms. Ritu, the spelling mistake, you have corrected the spelling mistake right now. You click on the cross button over here. Cancel, click on cancel.
Yes, ma'am.
Click on close over here. Yeah.
Close on the top of the right.
Yeah, top right. There's a cross button after the question mark.
Top right.
You are taking all your time, Ritu, into these things. Cancel is written there. You click on cancel or click on cross.
It is there on this box only, the white box only. There is a cross button, Ms. Ritu. Yeah, click on close.
The association can I, may I audible, ma'am?
Yeah, you are audible, Ms. Ritu.
The association between Bishop score and mode of delivery was found to be highly significant, with in patient having Bishop score less than 3 being highly prone to cesarean delivery. Cervi prime, which is PGE2 del, and ICF with cervi prime was associated with significant highest cesarean delivery as compared to cervical ripening agent intercervical Foley, as we shown in my table number subsequent table. And the result was gestational age is 37 to 39 week, 6 to 8 induction was associated with 66% cesarean delivery, and gestational age between 24 to 33 weeks, 8 induction was associated with 52% of cesarean delivery, but the association was not statistically significant. No statistically insignificant association was found while comparing intervals since previous cesarean section with one mode of delivery. Out of 116 women delivering vaginal, only 4 women only 4 women had complication, and all 4 women having PPS. The tragic thing was that 1 woman expired due to intractable PPS in spite of all measurement. Out of 104 women delivered cesarean section, 5 women required ICU care due to problem of antepartum eclampsia and heart disease. 1 woman had cesarean scar adhesion, which was repaired, and 8 women having abdominal wound problem. Baby requiring NNU admission were significant more in cesarean group. Conclusion: Bishop score, labor induction, age, obesity, previous vaginal birth, indication for previous cesarean section should be considered as the factor affecting successful of VBAC. A more open mind partially of induction of labor in women with previous cesarean section might reduce the severe cesarean section. Previous normal and vaginal delivery increasing the success rate of VBAC. Limitation of study. Induction of labor is a good option in women with previous cesarean section in women with but is required a meticulous selection of cases. It should be carried out in tertiary care center where there is adequate manpower to supervise delivery, reducing complication related VBAC. Similar result may be noted and center other than tertiary care center. Strength of study, the study comprehensively, critically, and qualitatively assess the association between maternal and fetal factor and chance of achieving following induction of labor, including factor both from historical and current pregnancy. Even there is a critical study. The careful study was made of the medical record of all women included, which make the result even more reliable. Recommendation of study: we should recommend that all women with previous infection should have routine dating scan to avoid infection cause. Randomized control trial with larger sample size should be performed to evaluate more precise and accurate result. Thank you, ma'am.
Ritu, we cannot allow you the discussion part because the time you have taken is pretty long. We call upon the next speaker. Karishma Sharma is we are calling upon because she has to go for her COVID duty. Karishma, are you ready? Karishma Sharma.
My screen is visible.
Yes, Miss Karishma, your slides are visible. May I request you to switch on your video as well?
Ma'am, I have shared the screen, so my video will not be there. Okay, ma'am. Okay, I'll start my video. Ma'am, am I visible? I'm not able to see my video. Ma'am, should I start?
Yeah, please start. Open your video.
Okay. Okay, ma'am. Good morning, everybody. My topic is to study the association between maternal serum homocysteine level with the preterm labor. And my name is Dr. Karishma. I'm a PG junior resident third year in Motilal Nehru Medical College, Prayagraj. First, the introduction. The World Health Organization estimates that preterm birth affect 11% of pregnancies worldwide, representing nearly 15 million births in 2010. Despite decades of research into the causes of preterm birth, the biological causes of preterm birth remain largely unknown. Therefore, estimating the likelihood of spontaneous preterm delivery is essential to provide the best clinical interventions that may improve neonatal outcome and save valuable resources. The diagnostic significance of the available methods for assessing the likelihood of spontaneous preterm delivery are limited. Therefore, new markers are required to identify precisely pregnant women who have a high risk of preterm birth. The increased homocysteine level was suggested to cause preterm labor through induction of placental vascular endothelial dysfunction that induces inflammatory hormonal cellular effect that hasten the sequence of events ending in preterm labor. Experimental studies reveal that moderately elevated homocysteine concentration may induce cytotoxic and oxidative stress leading to endothelial cell impairment. Aims and objectives: to study the relationship between maternal serum homocysteine level during mid-trimester 14 to 27 weeks of gestation and preterm birth, to establish hyperhomocysteinemia as a potent modifiable risk factor of preterm birth. Material and method: an analytical prospective cross-sectional study was done on 205 pregnant women attending outpatient department as well as emergency admissions in labor room in SRN Hospital and KNMH Hospital, Department of Obs and Gynae, MLN Medical College, Prayagraj, over a period of 1 year from September 2019 to September 2020. Inclusion criteria: those women who are willing to participate, women with singleton pregnancy, gestation age between 14 to 27 weeks of gestation. Exclusion criteria: pregnant women with multiple gestation, malpresentations, preterm, premature rupture of membrane, active labor, diagnosed cervical insufficiency, uterine or fetal congenital abnormalities, placenta previa, IUGR, oligopolyhydramnios, infections or inflammatory disease, fetal distress diagnosed by fetal CTG or fetal Doppler indices, medical problems like hypertensive disorder of pregnancy, anemia, GDM, or medically indicated preterm delivery, those using lipid altering medications, insulin, antidepressants, thyroid hormones, and sleeping medications. Venous blood sample was taken after overnight fasting for serum homocysteine estimation and serum separated by centrifugation, serum versus by chemiluminescence assay technique. Serum homocysteine level of 515 micromole per liter was considered normal. Result: out of 179 antenatal patients, 105 had serum homocysteine level less than 5, while 74 had serum homocysteine level more than 5. The variable serum homocysteine was not normally distributed. The p-value was less than 0.001, which was significant. The mean of serum homocysteine was 9.88 the median of serum homocysteine was 4.56. The serum homocysteine level ranged from 2.98 to 31.98. This figure is showing the distribution of serum homocysteine level in my patients. The AURC for serum homocysteine predicting preterm labor was 0.864, thus demonstrating good diagnostic performance. It was statistically significant. At a cutoff of serum homocysteine, it predicts preterm labor with a sensitivity of 78% and a specificity of 94%. The odds ratio was 58.48. The relative risk for preterm labor when serum homocysteine is more than 9.87 was 4.94. The variable serum homocysteine was not normally distributed in the two subgroups. The mean of serum homocysteine in the preterm group was 15.36, while the mean of serum homocysteine in the term group was 4.59. The serum homocysteine in the preterm group ranged from 3.27 to 31.98, while in the term group ranged from 2.98 to 20.97. This is the box and whisker plot depicting the distribution of serum homocysteine in the two groups. The current study shows significant higher levels of maternal serum homocysteine in preterm compared with the term delivery group. These conclusions were supported by the findings of other authors, although the evidence is weak. Kramer et al. And Hu et al. Proved that SPTD was correlated with the elevated maternal serum homocysteine level during the second and third trimester. However, Knudsen et al. failed to prove such association. Walser et al. In their large Norwegian study showed significantly higher maternal homocysteine level few years following conception in women with history of preterm labor. However, Ronberg et al. Showed an association between elevated preconception homocysteine level and preterm birth. These findings attract the attention to the possible role of increased homocysteine level in the pathogenesis of preterm labor. My conclusion is the current study showed that serum homocysteine level is a supportive biomarker for prediction of preterm birth. However, there are no available pursuit findings derived from larger studies for comparison because homocysteine has not been extensively evaluated in biomarker trials of complicated pregnancy other than preeclampsia. As clinicians move towards more biomarkers during pregnancy to assess risk of preterm birth, maternal serum homocysteine may turn out to be a useful component of biomarker risk profile. Thank you, ma'am.
Judges, please.
How did you determine the homocysteine levels? What test you have incorporated in your study?
Serum homocysteine was done by a serum chemiluminescence assay technique, and the serum was centrifugated. Venous fasting samples were taken from the woman, means taking the inclusion exclusion criteria, and between 14 to 27 weeks of gestational age.
What was the cost of it?
Ma'am, it costed around, means it is around 900 rupees, but on a subsidized rate, it was done at 650 rupees.
Okay. In what other conditions it is raised?
Ma'am, in a previous study done by my senior, it has been raised in eclampsia patients, has been studied in complicated pregnancies like preeclampsia and eclampsia.
Okay, only eclampsia and preeclampsia.
Yes, ma'am.
Okay. So what other biomarkers are there with preterm labor?
Other biomarkers are like serum fibronectin has also been studied, and means in my whole thesis I studied uterine artery PI index between 14 to 27 weeks of gestation and the lipid profile, and both all the three were established as potential biomarkers for the future.
Okay, okay.
In the serum lipid profile, ma'am, total cholesterol and triglycerides were the major markers if taken between 14 to 27 weeks of gestation, and it depicted more means preterm versus term, more depiction of preterm, but it didn't clarify between early and late preterm.
Okay, okay. Even lipid profile, you are saying that serum cholesterol is also an important biomarker.
Total cholesterol and serum triglyceride, ma'am, but no association was found in my study between HDL, LDL, and VLDL. Only between total cholesterol and TSH.
Okay, that's all. Dr. Poonam, if you want to ask anything.
Okay, then in that case, we can start with the next speaker.
Okay, thank you, ma'am. Thank you so much, ma'am.
Nisha Rani Divedi. Is she there? Nisha Rani Divedi?
Yes, ma'am. She's
Yes,
there.
ma'am. Yes, ma'am. Yes, ma'am. Can you start sharing?
Am I audible?
Yeah, you are.
Yeah.
Yes, ma'am. Ma'am, my screen is being shared.
No, not yet.
Oh, wait. Is it shared now?
Yes.
Yes.
Good afternoon, ma'am. Myself, Dr. Nisha Dwivedi, JR3, Department of Obs and Gynae from King George Medical University. The topic of my presentation is evaluation of SOS score, that is sepsis and obstetrics score in patients of obstetric sepsis, and its role in prediction of morbidity and mortality. Introduction. The sepsis and obstetric score is a very recent scoring system designed specifically for obstetric population, basically created to identify the need of intensive care unit admission or triaging in pregnant and postpartum women who presented with signs of sepsis. SOS comprises of total 8 parameters, which include clinical as well as biochemical. Total score ranges from 0 to 22. A cutoff of 6 was taken for severity of sepsis. Then this is the SOS score chart. It comprises of total 8 parameters, including temperature, systolic blood pressure, heart rate, respiratory rate, saturation, WBC count, percentage of immature neutrophils, and lactic acid level. Now, aims and objectives of my study are calculation of SOS score, validation of SOS score in patients of obstetric sepsis, evaluation of need of critical care support on the basis of SOS score, and evaluation of associated morbidity and mortality on the basis of SOS score. It was a prospective observational study conducted over a period of 1 year in Department of Obs and Gynae in collaboration with Intensive Care Unit Trauma Center, KGMU, Lucknow. Inclusion criteria was patient and guardians giving consent, patients of the age group 20 to 40 years, all pregnant, post-abortal, and postpartum women who presented with clinical signs of sepsis were included in this criteria. Severe sepsis was defined as an infection related to one or more than one organ dysfunction. A separate documentation was done according to SS criteria. And this is the flow chart of my study. Patients with suspected maternal sepsis were enrolled on the basis of SIRS criteria and respective definitions of P sepsis, chorioamnionitis, and septic abortion. Initially, we took 161 patients. 6 patients rejected to participate in the study, and 5 patients were not fulfilling the criteria. Finally, 150 patients were remained in my study, whose detailed history was taken, physical examination, obstetric examination, and laboratory parameters were done, and SS score was calculated. 89 patients had a score of more than or equal to 6, and 61 had a score less than 6. Out of the patients who had a score more than or equal to 6, organ failure was present in 66 patients, and those patients were considered as having severe sepsis. Among the patients who had a score of less than 6, only 20 patients presented with organ failure, and 41 patients had non-severe sepsis. Now, comparison of SOS various variables of SOS score, we find that clinically, if we are studying individual parameters of SOS scores, even they are showing positive p-value. That is, all the parameters are proving to be significant in our study. Now, distribution of studied patients on the basis of SOS score requiring critical care support. In our study, out of 150 patients, 112 patients required critical care support who presented with signs of sepsis, which comprises of 74.7%. Now, distribution of organ failure among the studied patients. Among the studied patients, total 86 patients in our study presented with organ failure, out of which the maximum organ failure was found was renal failure, followed by MODS, that is multiple organ dysfunction syndrome, which comprises of 2 or more than 2 organ system dysfunctions, followed by hepatobiliary and cardiac and CNS. Now, association of SOS score and other outcome variables. When we are comparing our SOS score results with critical care support, need of critical care support, organ failure and hemodialysis, need of hemodialysis and outcome, we find there was find a significant p-value for critical care support, organ failure and outcome. That is, SOS score was clearly very important, clearly proved to be significant in assessment of need of critical care support, organ failure and outcome. Now, sensitivity is talking about sensitivity, especially regarding with respect to severity of sepsis, that is signs of sepsis plus organ failure. Our study had a sensitivity of 74.16%, and accuracy of 71.33%. In assessment of critical care support, the sensitivity of the score was 82.02%. And regarding correlation with outcome, the score had a specificity of 95.08%, although the sensitivity regarding outcome was less, that was 32.5%. Now, talking about culture positivity, the maximum culture positivity was found in urine culture. Urine culture followed by vaginal urine culture followed by blood culture positivity, followed by vaginal culture positivity, followed by pus culture positivity. Now we also had a follow-up period of 12 weeks. We followed up the patients at 6 weeks and 12 weeks. And as per Kalpan mirror analysis curve, on the basis of Kalpan mirror analysis, it was observed that maximum deaths were observed within 40 days of admission. Now, strength of my study were the study was it was inexpensive. It was done at a specific point of time. It captured multiple variables. It was relatively, it had a relatively larger sample size, which was major strength of my study. And we have also included a brief follow-up period of our patients, that is at 6 weeks and 12 weeks, who gave an extra, which gave an extra edge to my study by including Kalpan mirror analysis. The limitation was another limitation that there was no further follow-up after the patient being discharged. That is, in terms of long-term complication, there was no further follow-up of the patients. Conclusion: we found excellent correlation between SOS score and severity of sepsis, that is sepsis associated with organ failure, with a p-value of less than 0.001, and outcome when associating with outcome, the p-value was 0.007, which was clearly significant.
Nisha, please finish it off with your time.
Its correlation with the need of critical care support was satisfactory with a p-value of 0.02. However, we found that performance of SOS would be further enhanced if cutoff was slightly reduced from 6 to 5.5. The sensitivity of SOS is good in terms of severity and need of critical care support, while it had a good specificity in terms of outcome. The advantage of my study was that SOS is a novel specifically designed score for the obstetric population considering pregnancy physiology. In low-income countries like India with limited resources, it provides better triaging of the patients for need of intensive care support, therefore prevents misuse and wastage of resources. It is also useful in prediction of morbidity and mortality. Thank you, ma'am.
So we can only have one question for her. If the judges have any questions, please, just one question we can ask. Sorry. Are there any queries or Dr. Rehana, Dr. Poonam?
Dr. Nisha, besides SOS, what is the other similar type of parameter which can be used for ICU patients' outcome?
Ma'am, we can use SOFA.
Yeah, SOFA. So didn't you think that which one will be more better?
Ma'am, obviously, when we compare the scores, the SOFA is better, but provided in this score, none of the scores framed earlier or studied earlier are in considering pregnancy physiology. In this score, the certain physiological changes in pregnancy have been considered. So it is the first score which has been framed according to changes in physiology of pregnancy. Only 1 or 2 studies have been done till yet.
Okay. Okay, Dr. Neelma, we can call Dr. Poonam if she wants to.
Next, Pooja Mishra, is she there?
Yes, ma'am.
Start.
क्या चल रहा है? मुझे तो यहाँ पे कुछ नहीं सुन रहा है। वॉल्यूम नेट की मतलब सभी जगह प्रॉब्लम आ रही है। कुछ मेरे में तो कुछ नहीं सुन रहा है।
Do we have the next speaker, Dr. Pooja?
Yes,
are you there?
Yes, ma'am.
Pooja,
please share the screen.
Yes, ma'am, I'm sharing.
Please share your.
Hurry up, please.
शालिनी गौतम है, देखना नेक्स्ट उसमें हमारे उसमें
Shalini Gautam.
Is Shalini Gautam there? Let her be ready.
Miss Pooja, you need some help?
Yes, ma'am. I am unable to share my screen.
Pooja Mishra, you are the co-host also of the... If you can let me know what is the issue coming?
नेट की ना प्रॉब्लम से हो रही है.
I'll request you to all please be ready with your PPTs and check it in some other platform on Zoom.
Till that time we can see Shalini Gautam is there. Meher Narayan is there. Priyanka Jaiswal. Priyanka, I can see.
Yes, ma'am.
Priyanka, are you ready with your slide?
Yes, ma'am.
Just see if you can upload, then we will start with you.
Okay, ma'am.
Meanwhile, Pooja will see. We'll wait for her. Pooja Mishra का नहीं हो पा रहा है ना?
Ma'am, can you see my?
Yeah.
Please,
Your
please
slides
start.
are visible. You start.
One second. May I request everyone, whenever they are presenting, click on the slideshow mode so that any interruption in the PPTs is not visible, like click to add titles and all is not visible. Yeah, thank you.
Chalo, start. Priyanka, please start.
Good afternoon, respected teachers. I am Dr. Priyanka Jaiswal, PG second year from the Saraswati Institute of Medical Science. My topic of presentation is prevalence of thyroid dysfunction in abnormal uterine bleeding. In the women of thyroid disorder can cause the broad spectrum of the reproductive illnesses ranging from abnormal sexual development, infertility, menstrual irregularity, and the premature menopause. As we know, the thyroid disorder is the most common endocrine disorder in India, and the incidence of thyroid disorder is increases with the age, and its prevalence is around 26%. Both the hypothyroidism and the hyperthyroidism can lead to the menstrual irregularity. It is usually because of failure of LH production and ovulation which build up the endometrium and result in menorrhagia. Abnormal uterine bleeding is one of the most common and yet complicated clinical presentation, and in 10 to 20% of the women between the age group of 15 to 50 year of the age, abnormal uterine bleeding was present. So the timely detection of the thyroid dysfunction in the patient presenting with the abnormal uterine bleeding and the proper management can prevent the unnecessary surgical intervention. Hence, this study to evaluate the thyroid dysfunction in the patient having the abnormal uterine bleeding from the puberty till the menopause. The aim of our study is to study the prevalence of thyroid dysfunction in the patient suffering from abnormal uterine bleeding, an objective to study the distribution of euthyroidism, hypothyroidism, hyperthyroidism in the patient of abnormal uterine bleeding, and to study the different menstrual pattern in the women with the thyroid dysfunction. Material method, my study type is prospective observational study. Inclusion criteria, all the women between the age group of 15 to 50 year of the age with the abnormal uterine bleeding included in our study, and excluded the pregnant women with pathology like uterine fibroid, adenomyosis, genital tuberculosis, endometrial polyp, endometriosis, uterine malignancy, and those who are IUCD inserted in situ, women with the coagulation disorder, renal disorder, and the patient medication on the oral anticoagulant drug. Sample size 100 women attending the gynecological OPD meeting the eligibility criteria. The blood sample were analyzed by the hormonal analyzer method that is based on the enzyme linked fluorescent principle. The assay of manufacturer reference range is for the TSS 0.15 to 5 milliunit per liter, for T3 2.5 to 5.8 picomole per liter, and for the T4 11.5 to 23 picomole per liter. Result, uh, uh, this table showing the distribution of the patient according to the age. The maximum number of the patient in our study belong to the age group of 31 to 40 year, and the least number of the patient like 40 in the group of 41 to 45 year, that is 10%. This table showing the distribution of the patient according to the parity. Maximum number of the patient were multipara, followed by the para 2, that is 23%, followed by unmarried, that is 20%, and the least number were in nulliparas. Now, the distribution of the patient according to the bleeding pattern, maximum number of the patient having the heavy menstrual bleeding, that is 52%, followed by the acyclic bleeding 22% patient, polymenorrhagia 7%, polymenorrhea 6%, metrorrhagia in 4% of the patient, and hypomenorrhea in 2% of the patient, oligomenorrhea in 5% of the patient. Now, this table showing the distribution of the patient according to the thyroid dysfunction. 77% patient had euthyroid, 9% patient had overt hypothyroid, 12% patient had subclinical hypothyroid, and 2% patient had hyperthyroidism. Now, this table showing the different menstrual pattern according to the bleeding pattern and the thyroid dysfunction. Out of 24%, 24 patient, 83.3 patient had euthyroid, 8.3 had 8.3 hypothyroid. Out of 52 patient, 82.6 patient had euthyroid, 7.6 had hypothyroid, and 5% had 9.6 had the subclinical hypothyroid. And metrorrhagia and none of the patient of hypothyroidism and the hyperthyroidism showing the metrorrhagia and hypomenorrhea. Oligomenorrhea seen out of 5 patient, 40% patient of euthyroid, 20% patient of hypothyroid, and none of the patient and 40% patient of the hyperthyroidism. And polymenorrhea seen out of 7 patients, 57.14% of 14.28% patient had hypothyroid, and 28.5 patient have the subclinical hypothyroidism. Polymenorrhea seen out of 6 patients, 33.3 patient had euthyroid, 16.6 had hypothyroid, and 50% patient had the subclinical hypothyroid. Now they were showing the different bleeding pattern in the overt hypothyroidism, that's showing the 44.4% had the heavy menstrual bleeding, followed by 22.2 had the acyclical bleeding. And this pie chart also showing the different bleeding pattern in subclinical hypothyroidism, that is 14.6% had the heavy menstrual bleeding, and 25% had the polymenorrhea. So our study include that our study majority of the patients were in the age group of 31 to 48, that is correlated to other studies. In this study, the majority of the patients are multi-pattern, that is similar to the other studies. The prevalence of hypothyroidism is around 23%. That is also similar to the other studies like Kumar HS et al. And the Parmalila et al. Among the 100 patients, 23% had the thyroid dysfunction. Out of this, 90.54 had the hypothyroidism. That is also similar to the other study like Kumar HS et al. Most common menstrual bleeding pattern in
पूजा मिश्रा की स्क्रीन रेडी है, नेक्स्ट आ जाएगी वो। नहीं, इसका तो वहीं से तो वही है, या मेरे में कुछ प्रॉब्लम हुई है?
No, it has gone.
Priyanka, your screen has gone.
Your screen and your
slides.
Screen
Priyanka, you are on mute as well. Please take care of the buttons that everyone is clicking. Whoever is the co-host, everybody is the co-host. Please,
Yeah, just finish it off. Your time is already over. Just half minute to conclude.
Yes, ma'am. In our study, out of 12% of the subclinical hypothyroidism, 41.6 patients had the heavy menstrual bleeding, followed by the polymenorrhea, which was similar to the Thakur et al. This explains the occult HMB that has been found to be the early manifestation of the subclinical hypothyroidism. Our study conclude that the thyroid disorder should be considered as the important etiological factor for the menstrual abnormality. Thus, the biochemical evaluation of T3, T4, and the TSH estimation should be made mandatory in the AUB patient to detect the profound and the subclinical hypothyroidism. These patients with the thyroid dysfunction, if given the medical treatment, it is possible to avoid the unnecessary hormonal treatment and the costly surgical intervention.
Is that all?
Thank you.
Okay.
Hello. Hello,
Yeah.
Dr. Priyanka.
Yes, ma'am.
Can you tell me how to assess the blood loss of the patient? Which score?
Ma'am, according to the pictorial chart.
Pictorial chart. How to assess the score? You are not mentioning the score because the subclinical has a 41% is a heavy menstrual flow, or the score is required in your study. I think so.
Yes.
Okay, this is again bias of the selection criteria.
Yeah, you should have included the blood loss assessment, how you have measured that. Whether you have included calendar method for those who are having infrequent cycles. You have
Yes.
not mentioned what is pictorial blood assessment chart.
What is
That
PVS?
is what madam is asking.
Ma'am,
She didn't do this. That's why she don't do.
हाँ
नहीं पानी नहीं नीचे रहा कोई बात नहीं जो थोड़ा सा नीचे
pictorial chart. Basically, this it is, ma'am, diagnostic to see the different type of pad used and the bleeding pattern we have seen कि कितना जो है वो उसमें soaked है, like in sanitary pad about 30 to 40 cc of the blood loss, and 20 to 20 gauze into 20 gauze pad soak around the 500 ml of the blood loss.
No, beta, it is not like that. You read it, okay? It is not like this. So, next candidate, Dr. Neelima.
Pooja Mishra is ready with her slide.
Yeah.
Pooja?
Yes,
Yeah.
ma'am. I'm ready.
Chalo, share your slide, beta.
Yes, ma'am. Is it visible?
Yeah, it is visible.
Good afternoon, ma'am. Myself, Pooja Mishra, JR3 Ops and Gynae Department from KGMU, Lucknow. I am going to present on the topic to assess impact of early glycemic status on development of hypertensive disorder of pregnancy. As we all know, women with GDM are at higher risk of developing hypertensive disorder of pregnancy. Diabetic pregnancies complicated by preeclampsia are of great concern because of poor maternal and perinatal outcome. As HbA1c has been studied in literature as useful biomarker in early pregnancy for diagnosing hyperglycemia, and is also emerging to have correlation with subsequent development of HDP in our study. Aims and objective to assess the impact of early glycemic status on development of hypertensive disorder of pregnancy and correlation of biomarkers of early glycemic status, that is HbA1c, with markers of hypertensive disorder of pregnancy as mean arterial pressure, uterine artery Doppler, PAPE and PLGF. Material and methods. It was a prospective cohort study, 1 year duration. Sample size was 145. Inclusion criteria: all women attended antenatal OPD up to 14 weeks of gestation. Exclusion criteria were chronic hypertension, type 1 and type 2 diabetes. Women attended antenatal OPD up to 14 weeks of gestation were enrolled, and women followed on every antenatal visit for development of hypertensive disorder of pregnancy. Apart from routine antenatal investigation, we done specific investigation between 11 to 14 week mean arterial pressure, uterine artery Doppler, uterine artery PI, HbA1c, PAPE and PLGF between 11 to 14 weeks. Results of our studies are shown as table 1, showing the glycemic status of a study population. Out of 145 women registered in our study, 34.5 women developed GDM, and table 2 shows the association of glycemic status with presence of hypertensive disorder of pregnancy. That of, if we distribute the women of hypertensive disorder of pregnancy in GDM and non-GDM group, we identify that 58% of GDM women will develop hypertensive disorder of pregnancy in subsequent gestation. The table shows the association of glycemic status with biophysical markers as BMI, weight gain, mean arterial pressure, and uterine artery PI. We found that
the mean value was significantly higher. The mean value was significantly higher for all of these BMI, weight gain, and mean arterial pressure in uterine artery PI in GDM group as compared to non-GDM group. Table 4 shows the association of glycemic status with biochemical markers like HbA1c, PAPI, and PLGF, and we found that HbA1c was significantly higher in GDM group as compared to non-GDM, and PAPI and PLGF was lower in GDM group as compared to non-GDM group. This is quite interesting result. PAPI value was also found lower in GDM group. The table 5 shows the association of biophysical marker with presence of hypertensive disorder of pregnancy. We found that BMI, weight gain, mean arterial pressure, and uterine artery PI was significantly higher in HDP, hypertensive disorder of pregnancy group, as compared to non-HDP group. And if we compare the biochemical marker HbA1c, PAPI, and PLGF, we found that HbA1c was significantly higher in HDP group. This is correlated. HbA1c was significantly higher in HDP group as compared to non-HDP group, and PAPI and PLGF was significantly lower in HDP group as compared to non-HDP group. This is the table showing the distribution of biophysical and biochemical marker in HDP, non-HDP among women with GDM only. If we distribute, if we compare in GDM women, we found that DIPSI, HbA1c, mean arterial pressure, uterine artery PI was significantly higher in HDP women with GDM as compared to GDM without HDP, and PAPI and PLGF value was significantly lower in GDM women with HDP as compared to GDM women without HDP. This is the table showing the correlation of parameters of glycemic status and parameters indicating hypertensive disorder of pregnancy. Here HbA1c showing mild positive significant correlation with mean arterial pressure, mild positive significant correlation with uterine artery PI, and mild negative significant correlation with PAPI and PLGF. If we look for mean arterial pressure showing the weak positive significant correlation with uterine artery PI, and mild negative significant correlation with PAPI and PLGF. If we look for uterine artery PI showing the mild negative significant correlation with PAPI and PLGF, and here PAPI showing the moderate positive significant correlation with PLGF. The conclusion of our study was the biophysical and biochemical markers of glycemic status were significantly correlated with biophysical and biochemical markers of hypertensive disorder of pregnancy, suggestive of interplay in disease etiopathogenesis. Early detection of gestational diabetes with good antenatal care and strict glycemic control and strict blood pressure monitoring may decrease the burden of hypertensive disorder of pregnancy in our population also. The strength of our study is the novelty of concept of relating biophysical, biochemical markers of preeclampsia with gestational diabetes, and the study incorporated an extensive panel of markers which could be an emerging model to predict both hypertensive disorder of pregnancy and gestational diabetes and modify the disease course by optimal intervention at right time. The likely limitation of the study was relatively smaller sample size.
Chalo. We can have one question with her. She is already taken 6 + 1 minute.
Pooja, what was the cost of these tests which you have taken into account?
Ma'am, the kit for PAPI and PLGF was sanctioned by intramural grant by Research Cell Ethical Committee of rupees 1 lakh for this project.
Okay.
Yes, ma'am.
As such, how much it will cost to the patient?
Ma'am, 800 to 900 rupees for per women.
Both of these things, PLGF and PAPI.
Yes, ma'am. 1,000 rupees for both PAPI and PLGF.
This Dr. Pooja? This test is running in your institute?
Ma'am, no, this is not available in our institute. Ma'am, these tests, PAPI and PLGF was kit was purchased by research cell ethical committee, and then we apply these tests in pathology department in our
Okay, okay. You are giving a funding for this test.
yes,
Given by funding. Okay, okay. That's why it is a less cost. Otherwise, it is a 2,000 costing in the private sector.
yes.
Okay, okay. You are taking a fund for that. Okay, thank you.
Rupees for this project.
Okay, thank you, thank you, thank you.
Okay, next we can move on to next candidate.
Shalini
Do we have Shalini Gautam with us? I don't see her here.
Ma'am, I cannot see her. I've not
Even Meher Narayan is not there, I suppose. So we'll straight away shift to Mandvi Tarun, right? Mandvi is there?
Yes, she is.
Mandvi, you can share your slide, please.
बंद कर दो. कितनी सुंदर लगती है की बात है.
Miss Manvi, if you may please start your screen sharing.
Mandvi, are you there or not? Mandvi, are you able to listen?
Audible?
Yes.
Manvi,
Is it
may I
visible?
request you to switch on your audio?
No.
Unmute yourself, Mandvi.
Am I able, ma'am?
Yeah, you are.
But your screen is not being shared till now.
Is it visible now?
Yeah, it is visible now. Start, please.
Good afternoon, ma'am. Myself, Manvi Tarun. I am PG second year from SIMS Department of Ops and Gynae. My topic is prevalence maternal outcome, placental changes and its correlation with perinatal outcome in unbooked patient of iron deficiency anemia during third trimester. Anemia is one of the most common nutritional deficiency disorder of women. The prevalence in developed countries 14%, and in developing countries 51%, and in India it varies from 65 to 75%. Iron deficiency anemia is the most common cause of anemia during pregnancy, globally affecting about 32 million women. Placenta has a remarkable reserve capacity to withstand noxious environment. It is equally true that some unfavorable changes due to maternal anemia causes adverse effect on placenta, which ultimately might compromise the well-being of the fetus. The study prevalence maternal outcome, placental changes, and its correlation with perinatal outcome in unbooked patient of iron deficiency anemia during third trimester. Objectives are to evaluate degree and type of anemia, to determine the effect of iron deficiency anemia in pregnancy on maternal outcome, and to study changes in placenta and correlate with perinatal outcome. Material and methods. My study is prospective, descriptive, observational study. The present study was conducted in SIMS Hapur in Gynae department. A detailed history and examination was done of all the pregnant female in third trimester. During the study period, with special references to the severity of disease and to find out the maternal outcome, placental changes, and the correlation with perinatal outcome.
Inclusion criteria study was carried after proper clearance from ethical committee. Those women having HB more than 11 is control, and those women having HB less than 11 is in a study group. Exclusion criteria are all pregnant women in their first, second trimester, women with medical disorder excluded, and pregnant all the patients were studied in detail regarding age, literacy, socioeconomic status, parity, menstrual history, and past history. All the blood investigation and placenta histopathological examination were taken. The studies were divided into two groups. 50 were cases of anemia and 50 non-anemic control. Majority of the study subject belonged to the age group of 20 to 29 years, 76% in cases and 82% in control. Now the study subject according to socioeconomic status, where 68% cases belongs in lower category, whereas in control group only 20%. I have taken modified Kopuswamy socioeconomic classification. Study subject as per educational status. Here 62% cases belong in illiterate, whereas only 12% in control group. Study subject according to as a control group. Now the severity, according to the severity of anemia, mild 12%, moderate 68%, and severe 20%. Study subject according to variety, 40% of anemic patients were primary as against 54% in control. Table showing birth spacing interval in multiparous patient. 60% of the cases had birth spacing interval of less than 2 years, while it is only 35% in control group. Showing symptom analysis of anemic and control group. 82% of anemic women has symptoms suggestive of anemia. I have taken symptoms like fatigability, dyspnea, palpitation, and pedal edema in anemic cases. Showing distribution of a study subject according to past menstrual history. Hematinic intake in study subject in the present pregnancy. Iron intake was considered to be adequate in the woman who is intaking from beginning of the second trimester. 32% of cases and no hematinic intake, and 26% has adequate iron supplementation. Showing distribution of study subject then 80%, 28% in cases. Showing maternal complication. 18% of the cases belongs to preeclampsia, 14% preterm, then premature rupture of membrane 10%, 2% in eclampsia, 2% in antepartum hemorrhage, and congestive cardiac failure 2%. Showing the neonatal complication in a study subject, where preterm birth in cases is 15.90%, then stillbirth 9%, IUGR 6%, and end neonatal death 2%, and NICU admission were 13%. Now comparison of histopathological abnormality of placenta in non-anemic mother and anemic mother. Here blood vessels in cases as well as control, but there is increased sensation knot formation in cases 76.66%, and in control group only 6%. The study maternal illiteracy show low socioeconomic status, inadequate antenatal care, close birth spacing, poor nutrition as all risk factors for anemia in pregnancy. Anemia in pregnancy was also found to be associated with adverse maternal and perinatal outcome like preeclampsia, preterm labor, premature rupture of membrane, increased maternal morbidity, neonatal morbidity, and mortality. Efforts should be made for overall improvement of living status of women. And iron deficiency anemia was the most common type. Therefore, adequate iron and folic acid prophylaxis is a must in all antenatal women. And proper antenatal care is the basic requirement for prevention, early detection, and treatment of anemia. Thank you, ma'am.
Okay, so finished well in time.
Mandavi, why you have incorporated placenta also with anemia?
Ma'am, because as we can see, iron deficiency anemia is most common in nutritional anemia, and there are due to hypoxia, there are the changes we can see in placenta, and so that
So
I have
have you
included.
incorporated placental size and any morphometric parameter of placenta?
No, ma'am. Basically, I pathological examination only.
Gross findings of placenta, thickness, the cord length, all these things.
No, ma'am. No, I have
Because
not.
what changes will occur with hypoxia?
We
You
can
have
see
incorporated only
accentomegaly as well as
histopathological.
we can see both. Yes, ma'am. But we can see the gross changes. We can see small placenta, large placenta, and there is also there may be cord changes in
You
cord
have
also we can
not
see. But I have
commented
not
on
included
those
in my
things,
study.
no? You have not
Yes, I have
included.
not.
So with those findings like thrombosis and syncytial knots, what you want to interpret?
Yes, I'm totally agree with Dr.
I
Rehan.
want.
Nah. Yes, beta, you
And
have
due
to
to hypoxia.
mention the gross placental pathology compared to hematinic level of your patient. Then basically when the complication occur in anemia, as you shows, the preeclampsia is more common in anemia. Why? Tell me.
Ma'am, because
Okay, it's okay. Okay.
Okay.
We can now we have to move next.
Okay.
Next, yeah.
Is Sabha Khan there? Sabha?
Yes, ma'am.
हाँ चलो share your slides बेटा.
हाँ सारे हो गए
मतलब सब आ गए हैं.
हाँ,
हाँ, आ गए हैं सब.
वो जो दो बीच में नहीं आए थे वो आए हैं, बाद वाले सारे आ गए.
Is my screen visible?
Yeah, start.
Please start quickly.
Good afternoon, ma'am. I'm presenting on my topic, early transfer of critically ill obstetric patients to intensive care unit, effect on maternal mortality. My guide is Dr. Aisha Ahmed. Introduction. WHO in 2015 estimated that 830 women die every day due to preventable causes related to pregnancy and childbirth. Around 99% of these deaths took place in developing countries. Post 2015, WHO set the new global target of maternal mortality ratio as 70 per lakh live births by 2030, targeting to increase global equity in maternal mortality across the globe. Supplementary national target includes that no country should have maternal mortality ratio more than 140 per lakh live births, that is double the global average by 2030. Along with this, equity in maternal health care should be offered to all subpopulation within a country and across the globe, irrespective of financial and social status. Maternal mortality is sensitive to timely intervention and early transfer of critically ill obstetric patient to intensive care unit is an important component of care. Evidently, a randomized controlled trial to evaluate the impact of early transfer to ICU vis-a-vis delayed transfer holds practical and ethical implications. Aims and objectives: to study the effect of early transfer of critically ill obstetric patient to intensive care unit and its impact on maternal mortality and morbidity. This is a retrospective observational study in an 18-bedded adult medical and surgical ICU of tertiary care teaching hospital, where a research group comprising of specialists from different fields involved in medical care was instituted. Data was collected for all the obstetric patient pregnant or within 6 weeks postpartum admitted from 1st December 2017 to 30th November 2018. Triggering event for ICU admission were identified and the triggering event to ICU admission interval was noted. The triggering events were seizures, respiratory failure, shock, acute kidney injury, post-operative care for emergency cesarean section and exploratory laparotomy, post-operative care of elective cesarean section with complicated medical diseases. Triggering event in ICU admission interval was the time interval in days by the triggering event to ICU admission. Result: out of the 339 ICU admissions during the study period, 60 were obstetric patients, the survivors were 42 and the non-survivors were 18. Following were the demographic factors which was taken, which is age, SOFA score, the Apache 2 score. The infection was the most common complication in our study, which was followed by hypertensive disorder of the pregnancy and obstetric hemorrhage. All except one ICU admission were postpartum and post-abortion, and maximum was seen in postpartum 24 hours to 1 week. Respiratory failure was the most common triggering event that led to ICU admission. Survivors versus non-survivors. There were 42 survivors and 18 non-survivors. The non-survivors had significantly higher SOFA and Apache 2 score at ICU admission as compared to the survivors. The non-survivors required vasopressor support, mechanical ventilation, and dialysis more frequently than the survivors. The triggering event to ICU admission interval was significantly smaller in survivors as compared to the non-survivors. Timely transfer to ICU was associated with decreased mortality, and the p-value was found to be statistically significant. Now, a comparison of the demographic and clinical values between the survivors and the non-survivors were made, and the univariate analysis in which the variables like SOFA score and the Apache 2 score, the triggering event leading to ICU admission, the duration of vasopressor need for dialysis were found to be significant predictors of the mortality without having to adjust the other factors. The two variables were that is the need for vasopressor and need for mechanical ventilation. They could not be included in the study because 100% of the non-survivors required mechanical ventilation and the vasopressor support. Now, the predictors of non-survivors, in multivariate analysis, so the only triggering event to ICU admission interval and the need of dialysis were found significant, and they were the independent risk factor of the morbidity and the mortality. In the discussion part, this is the study that highlights the importance of the early transfer of critically ill obstetric patient to intensive care unit. ICU and government sectors are always running short of beds due to high rates of patient admission, and the majority of the patients are first waitlisted until a bed is available. The higher Apache and SOFA score at the time of admission among non-survivors underline the fact that organ failure increases during waiting period, leading to deterioration in the parameters by the time the patient reaches the ICU. So the impact of delay was framed as a 3 delay framework, which was introduced, which was responsible for the maternal death, and in which it was divided into 3 phases. That is the phase 1 delay, in which the delay in the woman and the family seeking help. Phase 2 delay, which was delay in reaching appropriate healthcare center. Phase 3 delay, which was delay in receiving appropriate treatment after reaching the healthcare facility. This was subdivided in delay in receiving definitive obstetric intervention and delay in receiving life support. Delay in receiving life support was further subclassified as delay in identifying critically ill obstetric patient, delay in getting ICU bed, and delay in inter-hospital or interdepartmental transportation. Conclusion. The early ICU transfer of obstetrically ill, critically ill patient associated with decreased maternal mortality, a structured and protocolized approach is needed to provide appropriate and timely life support to these potentially salvageable group of critically ill patients. Thank you, ma'am.
Sabha, have you analyzed what was the impact of multi-organ failure patients? Like you are saying that all the patients who are critically ill should be taken directly into ICU. That is very true. That is the actually what is the treatment that patient needs. But the outcome of the critically ill patients also depend upon their severity of their illness. Have you analyzed that also?
Ma'am, that can be analyzed by the bedside scoring system such as Q SOFA score, quick SOFA scoring system, which will help us in analyzing if the patient requires ICU admission or not. Quick SOFA scoring system includes the 3 scores, which is the respiratory rate, and the GCS of the patient, and also the systolic blood pressure. These are the parameters which are readily and easily available, which we can evaluate bedside. And on the basis of that, we can decide if the patient needs ICU admission or shifting to the ICU or not.
Hello.
Outcome of the patients. Yeah.
Yeah, ma'am. Continue, ma'am.
No, Dr. Poonam, you ask.
Yeah. Dr. Shava?
Yes, ma'am.
Yes, ma'am. Already said this thing. Ki you admitted right now all patient in a ICU level. You will have, first of all, I think it is a level 1 to 2 or 3. It should be assessed at the time of triage. So triage level 2 to 3 or 3 to 2. This will be decided at the level of triage. So whatever SOFA score, because the respiratory rate or ma'am said the multi-organ, that's required direct transfer to ICU. वो समझ में आया?
Yes, ma'am.
ना तो मल्टी ऑर्गन में भी तुमने नहीं बताया कि किडनी स्टेटस एंड रेस्पिरेटरी व्हाटएवर.
Yes, ma'am. If we take the SOFA score, not the quick SOFA, the SOFA score, which includes 6 parameters, then we will see for the GCS of the patient, the cardiovascular system analysis, the liver profile, the coagulation profile, the renal profile.
So it means that all patient has deteriorate all this condition because the level 3 patient goes directly to ICU level at this time.
Yes, ma'am.
Okay, all patient are level 3.
Yes, ma'am.
Okay.
But Sabha, your patients, like critically ill patients, as Dr. Poonam is saying, some patients will be in stage 3. They are already very sick. In them, whether you admit them in ICU on ventilator, the outcome will be poor.
Yes, ma'am. That is why, ma'am.
Have you highlighted on to that?
Yes, ma'am.
What was the cause in those patients?
Ma'am, in patients
can we improve with early admission? Can we improve their outcome?
Yes, ma'am. We can improve
into ICU.
Yes, ma'am. If the status,
but that has not been addressed upon.
Yes, it is not mentioned in your study, beta.
Yes, ma'am. Ma'am, that part I have talked about it during my presentation, that in patients who required mechanical ventilation or the vasopressor support, those who were very critically ill, those were
you are saying 100% mortality was there.
Yes, ma'am. Most in the non-survivors.
Ideally, you should have made a table in which, depending upon the Q SOFA score, what was the outcome of the patients on early ICU admission. That has not been shown.
Yes, ma'am. I will improvise that.
Yeah. Okay.
Thank you, ma'am.
Can we take the Shalini
yes,
Gautam?
Madam.
Shalini Gautam is there?
No, she's not there. I think we'll go with Kajal Singh.
Yes, ma'am.
Kajal, please upload your slides.
Yes, ma'am. Ma'am, shall I start?
Yeah, please start.
Good afternoon, everyone. I'm Dr. Kajal Singh, first year junior resident of ERAS Lucknow Medical College and Hospital. My guide is Dr. Aisha Ahmed, and the topic of my presentation is a structured training program for postgraduate students in obstetrics and gynecology, a pilot project. So in the introduction, postgraduate medical education in obstetrics and gynecology is usually based on a concept of learning by doing. However, we tend to forget that it is a training period which requires supervision and defined learning objectives. The Medical Council of India recommends standardization of postgraduate medical education to provide consistent level of training. My aim is to discuss the structured teaching program for postgraduate trainees in obstetrics and gynecology, to find out shortcomings of the program, analyze areas which are lacking and take suggestions for their improvement, to find out evaluation techniques preferred by postgraduate students for their overall assessment.
So for this, a cross-sectional study was conducted in Department of Obstetrics and Gynecology in Jawaharlal Nehru Medical College, Aligarh Muslim University, for a period of 6 months among 47 participants, and it was approved by Institutional Ethical Committee. A pre-validated questionnaire was provided to the postgraduate students and the feedback was recorded. They were also asked about the views on different aspects, and the satisfaction was rated on a scale of 1 to 5, 1 being strongly disagree and 5 being strongly agree. Departmental decision was taken to improvise postgraduate training recommended by Medical Council of India, and an academic committee was set up. The entire curriculum was assessed and the teaching roster was constructed. 1 journal club, 1 case presentation a week, 2 to 3 seminars, practice drills once in 3 months, and role plays. A grievance committee was also instituted with an aim of solving various problems faced by the postgraduates. In the results, 30 out of 47 trainees filled up the questionnaire. Among them, 56.6 were the first year residents, 26.6 were the second year residents, and 16.6 were the third year residents. So coming to the table 1, which is about the feedback on teaching and assessment, it was seen that a majority, that is 80% of students, found orientation program beneficial, and there was also a high level of acceptance that was seen in the morning report presentation, and then almost 96% agreed that they have ample time to prepare for their seminars. And there were also quite a positive response which was seen in the rating of teaching sessions. Then coming to this, 40% of students agreed that the teaching environment was friendly, and 63.3% students agreed that they were encouraged for participation in workshop and different conferences. So in table 2, coming to the feedback on research guidance, students also reported that they were provided adequate time for them to research for their topic. They were also allowed to choose the topic of their interest. Many people agreed that there was adequate mentorship during their thesis work, and 80% of students did agree that the guide allotment was fair, and quite a few, that is 76% of students, agreed that appropriate motivation was given to them for presenting their thesis work. Table 3, that is feedback on clinical duties. Students were satisfied that the timely rotation of residents in different units were there. They also found some amount of, they also found it beneficial that HDU postings, the HDU postings and the infertility clinical postings were also beneficial to them. They were provided sufficient opportunities for hands-on training, and also there was appropriate workload sharing among the residents. In table 4, that is about the feedback on the administrative aspect, the students were quite happy with the grievance settlement, and they were also happy on receiving their salaries on time. A little dissatisfaction was seen in the participation of paramedical staff in the patient management, and there was also a little dissatisfaction in the regular display of evidence. Many countries follow a competence-based, properly structured with defined standards of knowledge, skill, behavior for postgraduate training. However, Medical Council of India has recently laid down detailed guidelines for training and evaluation. India has a 3-year postgraduate degree program in which residents develop skills for patient management. This duration is shorter than the training period of many other countries. The shorter duration and lack of structure program may be responsible for incomplete coverage of postgraduate curriculum. A combination of different modalities have shown positive results in many developed countries. So in this table 5, there are open-ended questions in which the students suggested that at least once a week, consulted teaching should be incorporated in the teaching program, and also suggested that focus on application of knowledge on the common clinical condition should be there. Training and assessments are complementary, and a tool of evaluation is a must. So for that, students felt that a formal test at the end of 2 to 3 months, which would be beneficial for them so that they will be able to revise the topics. Appreciation of work should be done for trainees who perform their duties diligently. Effective mentoring program is important due to higher stress involved. Despite a hectic schedule, it is possible to develop a structured training program for postgraduate trainees. However, it needs phenomenal efforts from both the part of faculty and the students. Thank you so much.
Judges?
Yeah, Kajal, you are from Eras Medical College, no?
Yes, ma'am.
You have conducted this study in AMU.
Yes, ma'am. I got actually, ma'am, my guide has provided me with with the data from Aligarh Muslim University. And ma'am, it was it was like recently done.
Recently done, okay.
Yes,
and these competencies which you have evaluated has been evaluated by somebody else, not you.
No, ma'am. I was provided with data with the help of my guide, ma'am. My guide helped me in that.
Okay.
Yes, ma'am.
Okay, what do you think competency based medical education in postgraduate? Do you think that your residency should be prolonged from 3 years to 7 years? You want a residency of 7 years?
Yes,
No,
according
ma'am,
to
not
her
for 7 years.
Dr. Yana, according to her
In
study,
UK,
I think
in
more.
US it is 7 years, in UK it is 6
ma'am.
years.
Yes, ma'am. And in
You
UK
are
it is
saying,
still from 3 to 8 years, ma'am.
Yeah. Dr. Poonam, any questions, please?
Yes, ma'am. According to her study, it should be, I think, in India 5 years. But but I just want to say, we compare to US, UK and US, there is a lack of ratio of doctor and patient ratio.
Yes,
that's why they didn't get more experience than Indian scenario. In our Indian scenario, government institute a lot of patient doctor ratio. That's why 3 years sufficient for us. I think so. This is my opinion.
Yes,
ma'am. I think I am right.
Yeah, madam, absolutely. If we are going to do residency of 5 to 7 years, our PGs, but it will be beneficial for the medical colleges.
Yes.
Okay, next.
Next, we can call Prachi. Prachi is there?
Yes, ma'am.
Chalo, Prachi, share your slides.
Yes, ma'am. Ma'am, is it visible?
Yeah.
Okay. My topic for my good afternoon, everybody. My paper presentation is on. Hello, good afternoon, everybody. My paper presentation is on the topic a study to assess various modalities of induction of labor and its feto-maternal outcomes. My supervisor was Professor Nisha Rani ma'am from IMS BHA. Okay. Labor induction is a clinical intervention which benefits the mother or newborn when continuation of pregnancy poses a risk or danger to the outcome of pregnancy. Induction of labor is certainly one of the most frequently performed obstetric procedures in the world. The goal of success in induction of labor is to achieve a spontaneous vaginal delivery with the possibility to initiate adequate uterine contraction, favorable cervical changes without hyperstimulation, fetal compromise or distress within reasonable time frame and with minimal maternal discomfort. Aims and objective of my study was to compare various modalities of induction of labor alone or in combination and to evaluate different outcomes in mother and baby. This was a prospective observational study done in 100 pregnant mothers who were admitted in labor room, Department of Obs and Gynae, Sir Sundarlal Hospital, Banaras Hindu University, Varanasi between 2018 and 2020. Written informed consent was taken. Written informed consent was taken, ethical committee clearance was done, history, general, obstetrical, vaginal examination to report investigation and recent obstetrical ultrasound was done. Fetal monitoring was done except for those with confirmed IUFD cases. Methods used for dinoprostol, misoprostol, oxytocin, amniotomy, and mechanical dilatation. So incidence of labor, incidence of induction of labor in our hospital in 2 years was 20.36%.
Now, mostly the indication for induction were crossing of dates, oligohydramnios, PROM, obstetrical cholestasis, PIH, elective induction. After the ARISE study done, UPCOG recommends after 39 weeks we can go for elective induction, and there were 10% of elective induction in our in my study as well. IUFD 7% were there. Okay. In our study, 59 pregnant mothers delivered vaginally, out of which 67.8% were primary gravida. 41 pregnant mothers underwent LSCS, out of which majority were primary gravida. So there was a strong association between parity and mode of delivery. Almost all mothers who underwent LSCS were term pregnancies. So this also depicts that there was a strong association between gestational age and mode of delivery. So out of 59 patients who delivered vaginally, 72.9% of the babies were handed over to the mother, 15.3% were admitted in NICU. 41 patients underwent LSCS for various reasons, out of which 68.3% of the babies were handed over to mother, and 31.7% were admitted in NICU. So all pregnant women who were induced for IUFD were delivered vaginally. So there was a strong association between outcome of baby and mode of delivery. There was single and combination of methods used for induction, dinoprostone being the most common, followed by the rest. After dinoprostone, 74% of the babies were handed over to the mother, 21% required NICU admission. After dinoprostone, 25.8% required NICU admission. All the 7 USG diagnosed IUFD cases, 6 were induced with misoprostol and all delivered vaginally. Oxytocin was method of induction in 6 women, and 33.3% were admitted in NICU. Amniotomy was done in concurrent with another method. 15.4% of the babies were admitted in NICU. Mechanical dilatation was done only in 2 IUFD babies and was successful. So we conclude that CTG abnormalities was more seen in misoprostol. Meconium was also seen more with misoprostol, but failed induction was observed more with dinoprostol in my study. Few LSCS were also done for failed progress of labor and chorioamnionitis as well. In majority of the study, majority of the patient who underwent induction with dinoprostol alone delivered by LSCS, 63.4%. There were 9 cases in which induction with dinoprostol followed by misoprostol was done for various indications like PPROM, IUFD, and 12.2% had undergone LSCS, while 6.8% delivered vaginally. Dinoprostol with ARM is more successful at delivering vaginally than other combination. NICU admissions, there were 22%. Most of them required only room air. Some required HFNC, nasoparental air and double CPAP, and 1 required ventilator. There was perinatal mortality of 2 babies in my study. Both were due to meconium aspiration syndrome. Now discussion. Mode of delivery, LCS, NICU, and perinatal mortality was more seen in my study than in other studies. Dinoprostol is not as good as in other studies, but oxytocin and mechanical dilatation had a better success rate. In a study done by Rajiv M. 2011, using dinoprostol for cervical primary followed by vaginal not hasten the progress of labor with reduction rate and outer with misoprostol. Although this is not observed in our study.
हम थोड़े दिन से यही कर रहे हैं क्योंकि यही है कि यहाँ पे स्टूडेंट्स
9 disturbances are there, not audible.
9 women received a combination of dinoprostol and misoprostol. 4 delivered vaginally and 5 delivered were shifted for LSCS due to pathological CTG and meconium aspiration, meconium stain amniotic fluid. There were 2 cases of perinatal mortality with dinoprostol and misoprostol, and both were due to meconium aspiration syndrome. So to summarize, combination methods took longer than single method of induction from active phase to delivery. Misoprostol and mechanical induction was most preferred in the cases of IUFD. CTG abnormality and meconium stain amniotic fluid was more seen with misoprostol, but failed induction was more seen with dinoprostol. Majority of the patients who underwent induction with dinoprostol alone delivered by LSCS. Dinoprostol with ARM had a good outcome. Induction with dinoprostol followed by misoprostol led to more LSCS than SVD, and there were 2% perinatal mortality with this combination and should be given very cautiously. Labor induction is not without its risk for its mother and particularly for the fetus. So variable outcomes, variables should be involved in induction of labor and ideally should be evaluated on a case-to-case basis. It is recommended that every birth center should have a local guideline regarding induction of labor. Once started, it should be continued to the end. And the importance of exercising patience when managing labor and delivery should be emphasized to provide a long-lasting downward trend of cesarean section rate in future. Thank you.
Prachi, you have incorporated all inductions for various reasons in the
Yes.
Your college.
Yes.
Now you tell me which one single agent you will prefer for induction at term without complications.
Ma'am, mechanical dilatation and dinoprostone. Mechanical dilatation.
But your study is saying that dinoprostone is not successful.
Yes, ma'am. But
in your study, you have concluded this thing.
Yes, ma'am. But it is much better than misoprostol. So I would say mechanical dilatation.
Why? Your study is not correlating with what you are saying. You are saying that dinoprostone is not successful in comparison to misoprostol.
Yes, ma'am.
So why you will prefer dinoprostone? What was the added advantage with dinoprostone?
Ma'am, there was no meconium stain liquor or abnormal CTG or any other problems with dinoprostone, except mainly failed induction of labor was there, because also our threshold in my setup was much less. Like threshold for LSCS was much less than it should be. We should, for failed induction, we should at least wait for 12 more hours and give oxytocin trial or anything after dinoprostone, after 3 gels. But in my setup, it is not that. That is why.
How many dinoprostone gel you were using?
Ma'am, 3.
What was the criteria?
3 gels, 6 hours apart.
6 hours apart.
Ma'am, this is the guidelines from Foxy as well.
And then you are saying that we were not waiting for 12 hours.
Like
so how long you were?
Ma'am, after reaching the active phase or after patient going for like 3 centimeter dilated or 2 centimeter dilated, we should have waited for oxytocin augmentation or anything as well.
Prachi?
Yes, ma'am.
Prachi, have you assessed the Bishop score prior to induction in each type of?
Yes, ma'am.
So it is not it is very insignificant in different marker. I think सभी parameter normal होनी चाहिए. अगर आप compare कर रहे हैं
all the Bishop score was less than equal to 6. All of them, all the patients.
If it is a 3 to 4 and you induces the misoprostol and I want to induce dinoprostol, so is there any difference? ऐसा कुछ होगा?
मैम प्राइमिंग के लिए हम लोग डाइनोप्रोस्टोन यूज कर रहे हैं मोस्टली. सो
it is a Bishop score is basically tells about the success of the labor and success of the induction.
Yes, ma'am.
So I think this is lack in your study.
Yeah, this is lagging.
That's
Bishop score. I did not mention it in my slides because it was a presentation of only 6 minutes and my thesis was like pretty long.
But it is a very important determinant of success of induction, beta. How can you ignore that?
Less than 6, ma'am. Less than 6.
Less than 6. It could be a 0, 3, 4, 2, 6, 5, 6. 5, 6 is a different success rate. 4, 3, 4 is a different success rate. So how we can assess the agent? You are saying the dinoprostol is not better because it increases the failure rate, fail induction more. I think this is, you get more fail induction because of poor assessment of the Bishop score. This is my thinking.
Yes, ma'am. Yes,
it could be. I think. Okay, thank you. Next.
Okay, thank you.
Can we have the next student now? Who's the next student?
How many students are left?
Vijay Sani.
2 are left. Vijay and Namra.
Okay.
Chalo. Vijay, please share your slides, Vijay.
Good afternoon, everybody. Can you speak, ma'am?
Please start.
Ji, ma'am. My paper presentation is on incidence LSCS after induction labor with dinocoaston gelling, nulliparous women tertiary care center. Guided by Dr. Bhavar Singh Joda, Senior Professor and Unit Head, Department of Gynae, Umed Hospital, Jodhpur, Rajasthan. Introduction. Cesarean section, one of the essential factor reducing risk intrapartum fetal death. Nevertheless, cesarean section also cause several complications. For mothers, surgical complications, bleeding, infection and thrombosis, and risk uterine rupture placenta prevent subsequent pregnancy increased. Overall, cesarean section associated high risk severe maternal morbidity and mortality when compared with vaginal delivery. Induction of labor, one of the most common procedures during the pregnancy. Data from National Center for Health Statistics for the last decade indicate that rate of labor induction increased gradually 9 to 20%. This increase noted both community hospital and university tertiary care hospital. Explanation: this jump in induction rate complex are multifactorial. Better planning birth by physician, patients and her family most common reason. Other reason include availability, FDA approved, cervical ripener, more release attitudes towards the marginally elective induction and legislative constraints. Labor induction, obstetric intervention.
Vijay, you have not made PPT. It is in the PDF format.
Ma'am, Word format.
Word format.
Ji.
Okay, I think there were some guidelines for presentation. Dr. Nilima.
Yes, it is a PDF. Word.
Ma'am, Word में ma'am.
Yeah, this is Word.
Word.
So should we allow it like all other candidates have
No,
presented?
we actually it should be in PPT, Vijay. How did you get confused by making it in own Word?
Ma'am, sorry, ma'am.
See, this is not actually the format of presentation at all. You've simply written the whole text. The main purpose, this thing of making the slides is gone. You didn't discuss with your guide? What do you say, Dr. Rehana and Dr. Poonam? I don't think this is
I don't think so, madam. It should not be allowed.
Yes, ma'am. It should not be allowed.
So sorry, Vijay. You should have seen the guidelines.
And since morning you are logged in, you must have seen everybody else has put on PP at least. Then you should have got it changed, है ना?
जी ma'am.
चलो कोई बात नहीं. Next time you prepare, you will have ample number of opportunities. Okay, make it sure that you put it over the slide next time.
Okay.
Okay, chalo. Who's the next one? Namra. Vijay, you stop your slide sharing.
जी मैम.
इसको बोल देंगे 10 मिनट का गैप देकर के नेक्स्ट क्वेश्चन पढ़ा लेगा.
Ma'am, I cannot.
Namra?
Ma'am, I cannot see Miss Namra here.
Namra was there some time back. Is she not there?
Yeah, she was there, but I cannot see her now.
If she's not there, then we'll stop because she has to be there. Already her time schedule is this much. She has to be there. Just make sure, Srishti, if she's not there, then we'll log out. We'll stop this thing. We can't wait for her.
Ma'am, I have 8 participants. There's Manjari, Seema, Mrinalini, Yapi, Poonam, Rehana. I mean, the judges are there, and 3 other participants are there.
Okay. All rest of them have already presented, no?
Yes, ma'am. As per the order that we did, I'll just call out the names that we didn't do. Okay. Shalini Gautam, Meher Narayan, Fatima
Usmani
and Sudakshini.
Yeah, they were not there, and now Namra is also not there.
Yeah.
Okay. It's okay. Okay, then Dr. Rehana and Dr. Poonam, I think we can close the session because these people are not there.
Yes,
Yeah,
ma'am.
yeah,
Yes, ma'am.
madam.
Yes,
Namra
ma'am.
has just entered.
Namra has just joined.
Her 2 marks would be deducted. We should deduct 2 marks of us for coming late.
Yeah, we must deduct her marks because what is this?
Yeah, yeah, she was supposed to be here at 1 o'clock at least. Chaliye. Chalo beta, Namra? Namra, are you there now? Chal, fatafat share your slides. We were almost closed. Huh? Chalo, share your slides first.
Yes, ma'am.
Neelam ma'am, if you can share your number in the chat box, I would like to have one call with you.
Me?
Yeah.
Yeah, sure. I'll just send.
Good afternoon, all teachers. My topic today, I'm myself, Dr. Namra Mohid, from KGMU. Today, I'm presenting the paper on flow-mediated dilatation of brachial artery is better marker than uterine artery Doppler velocimetry for prediction of preeclampsia in second half of the pregnancy. Introduction. Preeclampsia is a systemic disorder characterized by new onset hypertension after the 20th week of gestation, and it is the leading cause of maternal and perinatal morbidity and mortality. Its etiology although its etiology remain indistinct, systemic endothelial dysfunction and poor placentation have been recognized as a main event in pathogenesis of preeclampsia, and they can be easily assessed by the flow-mediated dilatation of brachial artery and uterine artery Doppler velocimetry. My aim and objective of my study is to compare the efficacy of flow-mediated dilatation of brachial artery and uterine artery Doppler for velocimetry for prediction of preeclampsia in second half of the pregnancy. Study was conducted in the Department of Obs and Gynae in collaboration with the Department of Radiodiagnosis in KGMU, Lucknow. Study. From the starting of the study, I have the 220 women, out of which 115 women are normotensive and 100 women are preeclampsia group. And in this paper, I have only took the 115 normotensive women, and I have followed these women till the delivery. Out of in the follow-up, 100 women remain normotensive till the delivery, which is comprised of the group 1, and 15 women will develop preeclampsia in follow-up, which comprises of the group 3. Methodology, I have taken the written and informed consent from every participant of the study, and after recruitment of all women were subjected for the all women are subjected for the current Doppler of uterine artery, which is performed in the supine position in a bed elevated at the 45 degree, and with the machine Toshiba Zyro Prime. The probe was transabdominal 3 to 7 megahertz curvilinear transmission was performed at the third at the maximum at 60 degree, and the waveform was using automated trace of at least 3 consecutive form, and the protodiastolic notch was a parameter considered of the wave flowmetry. And the second method which I used in the participant, the flow mediated dilatation. In this method, I have taken an image of vessels was obtained at approximately 5 centimeter above the elbow in longitudinal section during the minimum distension of the vessel to the cardiac diastole, and the image was frozen for obtaining the average of 3 measurement of the vessel caliber from the anterior posterior wall of the tunica media and adventitia intersurface, which is a D1, which is a baseline diameter. And the second diameter I have took after the cuff inflating up to the more than 250 millimeter of the pressure, and the cuff is slowly deflated over the period of 5 minutes. The mean of 3 measurement of again took which is comprised of at the 90th second of the deflation, which is a D2 after the diameter after the deflation of the cuff, and the percentage was calculated by the formula D2 minus D1 upon D1, and the flow mediated dilatation percentage was obtained. The result I have obtained out of 115 women, 15 out of 15 women who had developed a preeclampsia in follow-up, out of which 11 women are a group of non-severe preeclampsia and 4 women are of severe preeclampsia. And when we compare the flow mediated dilatation in two group, that is the normotensive and the converted group, the flow mediated dilatation is significantly different, and the percentage was 12.25 in group 1 and 10.05 in group 3. And although the baseline diameter is not significantly different, but after the occlusion and after the release of the occlusion, the diameter is significantly different. And when we do the second parameter, that is the uterine artery Doppler velocimetry in the patient, we found that in the second late trimester, the uterine artery PI and resistivity index and pulsatility index does not show a significant difference in group 1 and group 3. And when we have followed the result outcome in the both group, we have found that the slightly the termination of the group 3 patient has an earlier termination at the 37 week, and the group 1 has a 38 week average gestation is 38 week. And the mode of termination is, although the cesarean and vaginal delivery in both they are comparable, and the group 3 patient has more had more induction of labor. The baby outcome, although in both group they are comparable. From this result, I have concluded that the mean age of the patient in both the group was comparable in group 1 and group 3. But the flow mediated dilatation of brachial artery was lower in group 3 as compared to the normotensive group, and which is the p value is significantly difference between the two group. And by utilizing the cutoff point of 10.05, which is a median, the sensitivity of the flow mediated dilatation for the diagnosis of the preeclampsia was 65.3%, and specificity of 89.3%, and positive predictive value is 94%, and negative predictive value is 50%. And out of total 115 pregnant women, 39% patient had a cesarean section, and more patient had a vaginal delivery. The mean gestational age, the termination group 3 was significantly lower than group 1. The result endorsed that the evidence that FMD of the brachial artery is a test that has a better efficacy than uterine artery PI in the second half of the pregnancy. Thank you, ma'am.
Can you explain it physiological reason? What might be the reason for?
The physiological reason behind the lower dilatation in the patient who develop the preeclampsia is the release of nitric oxide, which is actually the basic endothelial dysfunction, which is the main event in the preeclampsia. And due to the lower availability of the nitric oxide in the patient of preeclampsia, which lead to the lesser vasodilatation, lesser dilatation of the cuff deflation in the patient of preeclampsia, and many other biochemical markers are responsible for the lesser vasodilatation in the preeclampsia. The preeclampsia is basically an endothelial disorder. The endothelial cell will play the main role in the pathogenesis of preeclampsia, and it is an endothelial cell which is responsible for the releasing of the nitric oxide, and which is the main substance to vasodilate in the pregnancy. In normal pregnancy, the nitric oxide is usually higher. But in preeclampsia, the nitric oxide is the endothelial due to endothelial.
But beta, what just a minute, Namra. This will be there with all the vessels of the body, you to say.
Yes, ma'am.
If any vessel we want to see, the same finding will be there.
Can
we compare it with the uterine artery PI, like the gestational age, if we are doing uterine artery PI by 14 weeks?
Yes, ma'am.
Will there be any difference?
Yes, ma'am. There is a difference because in preeclampsia, we have seen that the pathogenesis started from the placentation, and earlier when the second wave invade the trophoblast invade the second when the second wave trophoblastic invasion occur, this is the main time when the preeclampsia pathogenesis arises. So it is the time, it is the best time when we do the uterine artery PI. But the limitation of my study is that I have done in the late second half of the pregnancy after the trophoblastic invasion. So I cannot measure exactly the uterine artery PI changes in that. What is the flow mediated dilatation, that the endothelial cell dispersion is easily accessible and easily predictable in the third half of the pregnancy. So uterine is the best marker is from 11 to 13 week, 11 to 14 week. As early as we see that trophoblast is not properly invading, so we can do the better. We can start ecoaspirin and all the preventive measures we should.
Namra.
Yes, ma'am.
Namra, you said brachial artery test is better than uterine artery, but whatever you explain, it is a differ your opinion, because it is a generalized in a brachial artery. You didn't rule out the lipid status of the patient. Either you have to exclusion of or you show what is the status of the lipid of that patient.
Ma'am, actually, I have not included exclusion criteria in my slide. My exclusion criteria is any chronic disease. I have excluded the chronic hypertensive diseases, chronic coronary artery diseases, CAD.
But this is necessary. If you are
yes,
compared to generalized thing from the specific thing, one uterine artery is a specific for gestational age, and one is a generalized in whole body. As ma'am Rihanna is said, it is generalized in a whole body. Either nitric oxide theory is, or whatever lipid theory is there. So how we can say this is a predictive is a better than uterine artery?
Yes, ma'am. We have to in my study. I have excluded those pathology which impair the endothelial dysfunction. I have excluded the chronic kidney diseases. I have excluded the coronary artery diseases. I have excluded the
you have included the patient in second trimester. By that time, the second wave has already occurred. The low level of nitric oxide might already have been there.
Yes, ma'am.
So your study is to already biased. How come you say कि it is a better predictor?
Question answer में सबकी ऐसी तैसी हो जाती है.
And as compared to result that I have seen, that
it is only a biomarker of vasoconstriction. I don't think so कि radiologically you can only make it out. All the vessels of the body might be.
Yes, ma'am. Ma'am, it should be the other biochemical marker should be. It is the only a biophysical marker. I have included the Papa and PGLF study.
You should have incorporated other things also, and you are taking patients of preeclampsia, no?
Ma'am, I have included, but I have paper which is sharing is the group 1 and group 3, but I also included group 1 and group 2, which is group.
You have not very well explained now all the things like inclusion, exclusion criteria, what methodology you have followed. You have not explained properly. Okay. Dr. Poonam, if you want to ask.
Poonam, you have to ask anything else? Otherwise, I think Poonam is there. Poonam has probably left. Yeah,
I think she has left. Yeah.
Probably she had some work. It's okay. We have completed with our this thing. That was really nice, Dr. Rehana. So nice of you to be actively participating with. Thank you so very much for your time. It was very nice.
Most welcome, ma'am. Okay.
Just compile up your marks and send me. And
yeah, I'll send it.
Yeah. Okay. Thank you. Thank you, Srishti. Thank you so much for the technical support. And all the candidates who are there. Okay. Chalo, all the best. Chalo, bye. We'll leave the meeting now.
Okay. Thank you.